Can we start?
Yes.
Greetings. This is IIRSI Intraocular Implant and Refractive Society of India webinar on capsular challenges on phacoemulsification. We have a very good audience right across South America, Central America, North America, Europe, Africa, Asia, and Australia. We would be taking care of different aspects of capsular challenges. So here, what we would be, I would be sharing the initial video.
Just pause in between. We can't see the video. I think it's paused.
Share it again. We should share it again.
You should play it again. It's paused.
And try not to maximize it.
Also, when sharing, you have the option to stream it for video, like optimize it for video. Just do that.
Gaurav, welcome.
Thank you, sir.
Please.
I have with me Dr. Gaurav Luthra, who would be moderating this session with me. He is from Drishti Eye Hospital. He's a worthy son of a worthy ophthalmologist, chairman of ARC IRSI, and he's omnipresent in all webinars. Dr. Shruti would have been with me because of some problems. She could not make it. Then we have with us Dr. Mahipal Sachdev, who is the president of AIOS. He's the chairman scientific committee of IIRSI, and who has always believed in changing before the change. He has been responsible for spearheading the very face of Indian ophthalmology. Then we have the strong lady in Indian ophthalmology, Dr. Namrata Sharma. She is the secretary AIOS and professor in ophthalmology at RP Center, the Pinnacle Institute of Ophthalmology. George Biko is also with us. He's a dear friend, lecturer, University of Toronto. He's on the review panel of editorial boards of 10 ophthalmology journals and one of the premier surgeons of North America. John Hart, thanks Biko for introducing to John Hart, who is a dear friend. Kim and John form an admirable couple. He's a very popular figure across the world from Michigan, US. And he has a great insight into functioning of the phaco. And he has won so many awards in ASCRS. Then we have our own Partha Biswas. He's the chairman scientific committee, and he's of AIOS and director at BBI Foundation, Kolkata. Dr. Dhami, a very close friend. He's the president of IIRSI, director Dhami Eye Care Hospital. And then we have Deepak Magur, who has excellent videos, great insight, and he is at the Cataract and Glaucoma Services Magur Eye Care Center, Bidar, Karnataka, India. Dr. Rajendra Prasad is also there with us. He's the director, Rajendra Prasad Eye Institute, New Delhi, India, and Joshua Young, who everybody is familiar with because he's taking interviews left, right, and center. He's the clinical professor at Langone Health Tisch Hospital, New York, US. So we would be dealing with different aspects. So the first would be, the video has been played. The first is, the video has to be played again.
Rohit, you missed out 2-3 people.
Dr. Lisa. Rohit?
Yeah. No,
It'll be nice
no,
if
the faculty will be, the speakers will be introduced afterwards. So as and how we will go into it. So the first talk is going to be, so Dr. Tushya is sharing the video. Can you see the video now? The volume is not there.
Sound.
Sound is not working. Dr. Tushya, you have muted it. Mute. Dr. Tushya has muted it. So we will start with the first talk, which will be taken up by Professor Chi Soon Fake. So she would be talking on capsular challenges. So she has over 200 peer-reviewed scientific papers and books book chapters. So over to Dr. Chi.
So good evening to everyone around the world. I want to thank the RSI for kindly inviting me to participate in this webinar. So I've been asked to talk about how to do capsulorhexis in cases of severe zonulisis. So in these cases, sometimes it can be difficult to initiate the capsulorhexis, and we may need a 27-gauge needle to initiate. Make sure that the incisions are very snug, and I usually do not do my main incision until I've done the capsulorhexis. So initially, after puncturing the capsulorhexis, you want to actually support as well as grasp the capsule so that you provide the counterforce for tearing. Because in cases of severe zonulisis more than 180 degrees, usually, you have no choice where you have to start, and you may not be in a good position to have the zonules that are currently intact support your rhexis as you tear. So in order to provide the support, I usually use a micro grasper to grasp the capsule. So I grasp, the red one is actually what is actively moving, so I grasp it, and the other instrument is a capsulorhexis forceps, which I start to use to tear, to grasp the edge and to tear. And as I do that, I then change the capsulorhexis forceps to a micro grasper to provide the support, so it doesn't tear the capsule as it supports the capsule. And then hand over hand between the two instruments, I go around and do the capsulorhexis. These are the instruments which I use, all right? I use an MST micro grasper and a Kawai capsulorhexis forceps from ASICO, and I have no financial interest in anything which I'll be talking about. So this is a case of severe zonulisis following trauma, sports injury. And you'll see that the lens is relatively clear. It's in a 50-over-year-old gentleman, and the lens is actually in the anatomical position. There's no vitreous there, but you can see it coming on the side. So you make sure that there's no vitreous when you do your capsulorhexis. If there is and it's coming across the anterior capsule, you need to deal with that first. All right, so you see I've initiated the capsulorhexis with a capsulorhexis microforceps. And then I grasp the capsule edge. Now I've changed my instrument to a micro grasper, okay, so that it's not sharp. And you then provide the counterforce, hand over hand. Okay, so you hold on to one because there are no zonules here. You then tear with the other. And so what are you looking at for that guidance? How do you know how big your rhexis is? Basically, you look at the equator for that guidance. All right, you can see all these anterior capsule folds because of the absence of the zonular support. All right, this is actually completely absent, maybe only for a few in this area here, all right, near the incision which I'm using. and basically you need to provide counterforce all around. Okay, so you see that we are completing the rexus now, and it's only when you've completed the rexus then do you start to transfer the support, right, to other devices like a capsular bag hook, which you see me introducing, and you can see this is the area where the vitreous is herniating forward, and if you bring that forward, you provide the support because that phase is not interrupted. You can basically do without vitrectomy, right? So this is in the iris plane. Now, how about this case? You can see I'm indenting superiorly here, all right, to get that capsule, that lens seen, and then with the 27 gauge needle, I then spear it and bring it forward, all right? So you have to grasp the edge that you have slit, and then this is the capsular axis forceps, which is initiating the tear, and I'm supporting with my micro grasper. So you must have one instrument on the capsule at all times. And you see I have my hooks already positioned. They're very, very snug incisions so that I don't lose vitreous. But in this case, I had already done a vitrectomy going from the past planar approach. All right, so if you have an iris hook supporting the anterior capsule edge, that provides the counterforce. So in this case here, you see that I did not have to introduce the second instrument. But again, when I come round, the zonules here are weak and will not be able to provide the adequate counterforce for me to control the rexus direction and size. So before you tear, you grasp so that it can actually tear exactly the correct direction and the correct size. Because if you don't, it will tend to run out towards the equator because the lens tends to be globular when you do not have that support provided by the rexus, the tension on the anterior capsule. So you can see that's a patient that's hinged. I'm going to show you the third case now. It's a bit more challenging because this is tilting backwards and there's some vitreous which, you know, we're removing. It's really a wide intumescent lens and I have no good view. I mean, today I would really do a past planar approach, but this was done, I think it's like 15 years ago. All right, so I have to aspirate. I was worried. I used the capsular dye stain to stain, and I was very cautious because I didn't want to stain the vitreous, which you well can do, all right, if you are not careful. So I'm putting a 27 gauge needle to initiate the rexus as well as aspirate to decompress this intumescent lens. Now, some of you may be worried about Argentinian flag sign. I can assure you, you will practically never have Argentinian flag sign in such a case because it's the zonules that pull on the anterior capsule that make that capsule taut. So in the absence of this, you know, the tension from the anterior on the anterior capsule by the zonules, actually you can safely puncture this. I mean, I've done a few of these subluxated lenses where it's intumescent and the lens capsule, you know, is something that you would be worried about puncturing because of Argentinian flag sign, but you don't really have to worry because it's not actually pulled tautly because the zonules are actually gone in this case. Okay, so again, we do a hand over hand, and I'm providing the support where I can with iris hooks, and then when necessary, then I would put out the second instrument to help. In this case, this was done like 15 years ago. I merely used iris hooks to help me. So, you know, if you feel very uncomfortable about using your other hand to come in and, you know, a bimanual kind of capsular access, you can have hooks that help you to provide the necessary support. I'm going to show you one last case. Now, this is a different case scenario. This is a Marfan's syndrome in a 17-year-old. So this lens, unlike the rest, is not actually shifted. It's actually misshapen. So it's a small lens, and you do not want to do the rexus very big and far across superiorly from the screen here, because it's not that the equator superiorly is far out, all right? It's actually an oval-shaped lens because the zonules here have actually become very lax and stretched. And so I'm going to create an oval capsular rexus. Now, I don't always use hooks unless the pupil is small. In this case, the pupil was a little smaller than I would have liked it, so I use some iris hooks to show me a bit more of the capsule. You can see I'm provided the counterforce with my micro grasper, and you can use that grasp to actually pull the capsule, the lens more into view. All right, now what you see is a valuable tip that you can transfer from hand to hand, because sometimes as the capsule gets folded up, you lose view of where you are tearing. Right, so when you transfer from hand to hand, you never lose the edge of the capsule, like what you're seeing here. Okay, so this is just to show you for a Marfan's, and you can see the size. All right, the size of the rexis is really quite optimal in this case. So in conclusion, bimanual capsulorhexis is needed when the zonular loss is severe. All right, and you know it when you initiate it. All right, there's no counterforce, there's severe capsular folds and pseudoelasticity. So this is only performed because after you've got the lens restored to the anatomical position. So that's a very important step, right? Bring it to the correct position to be centered as well as vertically into the right position. And the lack of counter traction for capsulorhexis results in pseudoelasticity, like what you saw here. You know, the lens spinning along as you try to pull. You definitely need to then take a second instrument, or you can use an iris hook there to provide the counter force. All right, non-tooth micrograspers actually are used to grip the capsular rim to provide the counter force as well as stabilizing grip. And you do a hand over hand in the absence of the support of the zonules. And we look to the equator for guidance during the CCC in order to get that round capsulorhexis or appropriate shape, as in the Marfan's case, and also the correct size. Thank you.
Yeah. Thank you very much, Professor Chi. I think it was a ultimately fabulous presentation. So I have one question to ask. Why do you prefer iris hooks over capsular hooks?
Okay, so, you know, they are for different purposes. So sometimes in cases like this, I would use both iris hooks as well as capsule hooks. So in order to provide the counter force, I prefer to use an iris hook because its shape is such that it's just parallel to the capsule edge rather than digging deeper into the capsular bag. Okay, so once I've actually provided a counter force just on the rim of the capsule, I then switch to capsular bag hooks, which are different because they are much longer and they actually support the equator of the capsule. So that's important when you're doing phaco. In fact, I prefer to insert a capsular tension ring right at the outstart after completing the rexis, because that actually supports the equator better, because it's not just at the point where your capsule hooks are in contact with the equator.
I think what you show makes us believe that even dreams can be reality. Dr. Mahipal, your take on it, what would you say about it? Do you use flax, and how would you go with the flax? To what extent what Professor Chi has shown?
So actually what she has shown is in case you don't have the femtolaser capsulotomy available with you, because the lack of elasticity or a subluxation or even a mild vitreous coming into the anterior chamber on top of the capsule does not obviate the use of a femtolaser. The advantage of a femtolaser is that you could actually have capsulotomy customized to center it where it should be once the capsule comes back to the center. You can have it pupil maximized, you can have it centered on the pupil, you can have it centered on the limbus, or you can do it manually. So that is something which gives you the flexibility. I think in subluxated cataracts, etc., femtolaser, Professor Chi also uses that. That gives you that actually you don't have to dream to get a capsulotomy like Professor Chi does, because I think she is one of the best surgeons in the world. And not everyone is like us mortals are not equivalent to what she does. But I think obviously the basic principles are fantastic, because there is a loss of support on one area and you have to give a traction, counter traction and hand over hand techniques as she has shown. But I think femtolaser obviates that, and I think for a common or a ophthalmologist who does have a femto, a lot of these problems would be solved by using a femto for doing a capsulotomy in such cases.
So can I just say that, you know, for example, the first case, I actually put him under the femto, all right? And then he jerked his eye and the whole lens just shifted off. Okay, because these cases that I'm showing you with bimanual capsulorhexis are cases of severe zonulitis. Some of them are tipping into the vitreous, which makes it far too deep for the imaging of the capsulorhexis to be performed properly. It's tilted, you know, and it's going too far into the mid-vitreous for the laser to actually access. So I do use the femto laser. I agree completely. I love the laser where it can actually access the lens, but in severe cases like what I've shown you, very often it's not possible.
I'll agree with you. In severe cases, obviously it would not be possible because obviously there will be the planes would be very different between the top part and the bottom part. That I agree 100%. But majority of the times we get partial subluxations or subluxations that can be handled. But again, a person needs to be very deft at doing these things. I would rather go in and remove the lens in say subluxated and go in for a scleral fixated glued IOL or something like that. So that depends on the individual. But obviously your surgical skills are par excellence, and I think the points that you have raised are the basic principles are fantastic, and I think great videos. And as Rohit said, dreams would come true. Everyone will have hands like you and a brain like you.
Thank you.
George, your comments on this?
I think Dr. Lisa wants to say something. Yeah.
So.
If I may just briefly say, I published a paper with Boris Malyugin where he actually put his ring in and then used a hook to use it like a picture frame and center it on the lens, cutting off the hook and then using the femto, which was a feat that allows, to do a decentered lens with the femto laser if that is your preference. If you can, you do need a liquid interface to do that well, I believe.
Okay.
Yeah.
So now I would be.
Partha also wanted to say something. Partha.
Yeah. Yes, sir. Professor Chi, I really congratulate you on the wonderful teaching videos that you have had. And I've used your technique in 5 cases. The first 3 cases were utter failures. I absolutely failed, and my first hand ripped the capsule to the end, and I had a rip, and I had to abort that case and do lensectomy, vitrectomy, and then a scleral fixated IOL. But the next 2, what I realized is the tip of the forceps have to be very, very atraumatic. And I got one of our local manufacturers do it so that it was not a very sharp tip and it was very atraumatic. And the next 2 I got it, but obviously they were not as circular as yours, but I could carve the rexus with the 2 forceps that you have shown hand in hand. So I think it's a wonderful technique, and especially if femto is not available, and it can work, but it definitely needs a lot of practice.
But in severe subluxations, like Dr. Chi showed the last case, manually doing it is more, more customizable as compared to femto, and you may not be able to do femto in extreme subluxation, which is just jump to, one side, and you can't center it also, because how far will you go, because the lens is only half of it only can be seen. So I think it's a great technique in those kind of cases.
Thank you. I think we should move ahead now. So the next is going to be my talk. So yes. I would be talking about intumescent cataracts and intumescent.
Dr. Rohit, you'll allow me to introduce you for a moment.
Yeah, please.
That's my pleasant duty. So, he's always the modest kind who will not want to be introduced, but all the same. And yes, he does not need an introduction. Dr. Rohit Om Prakash has been instrumental. He's been a fantastic phacosurgeon. I've emulated him over the last 20 years that I've been seeing him do his amazing phaco techniques. He's a brilliant teacher, and he has, to his credit, several publications, several new techniques, the flap motility sign amongst them being the most popular one. And he has been organizing these IRSI winter conferences in Amritsar, which is the city of the Golden Temple, and they have been outstanding conferences every year in January, and we all look forward to these meetings every year now. With that small introduction, although there can be lots, I'll request Dr. Rohit to please speak on his intumescent cataracts and fibrotic capsules.
Thank you. Thanks, Dr. Gaurav. So I would be taking up intumescent cataracts. Well, the biggest challenge with these intumescent cataracts is the capsular axis, because all that we want to do is that we want to prevent the Argentinian flag sign. Well, the diagnosis of these fluid-filled, pearly white intumescent cataracts can be ascertained by the lens thickness, wherein there is an increased anterior-posterior diameter, subsequent to which the anterior chamber depth gets decreased. Slit lamp examination is also to be done. Biometry, when we do, we see that there are 2 or 3 spikes between the L1 and L2 spikes. And as far as the OCT is concerned, as Abhinav Dhami has already elucidated, that you see those fluid-filled pockets. So these are the way how you can really diagnose these, intumescent cataracts. We have to realize that there are basically 2 compartments in the lens, the anterior compartment and the posterior compartment. And these are all highly pressurized compartments. So, and the next important thing is that we have the pressure from behind also. This pressure from behind is also relevant in many cases, because for that at times we have to use intravenous mannitol. The pressure from the lids is also very important, which we need to take care of. So that can be, as Chi always says, that you use the Jaffe speculum, which produces the least amount of pressure on the globe. Anterior chamber pressure is also very important, for which, what we have to do is that we have to increase and equalize the pressure in the anterior chamber. So how do we do that? By adding a viscocohesive in the anterior chamber. So when we add the viscocohesive, what we are trying to do is, is it clear now? Is it clear? Hello?
Yes,
Hello?
it is very much.
Yeah. So this increases and equalizes the pressure in the anterior chamber. So this viscocohesive. So now, when in my practice, what I do is that if the anterior chamber depth is less than 2.3 millimeter, I use a 30 gauge needle aspiration. So what I do is that 30 gauge needle goes in and it trypan stained. I'm going through with a 30 gauge needle, and the moment I enter, that is the time when simultaneously you have to aspirate it. This simultaneous aspiration creates a situation where we have a concavity in the center. So this is another video just to show that the concavity, the moment I'm taking time to set my hand on the plunger, because the moment I go in, I have to aspirate it. And this aspiration, once done, takes care of the, the high intralenticular pressure which is inside. So now with this done, what is left with is that we have a high intralenticular pressure in the mid periphery. So now what we have to do is we create a small central CCC. So this small central CCC takes care of not going into the mid periphery. So you will see now what I do is that once that is done, through the microforceps, you go in and complete the central small capsular axis. So this central small capsular axis is done. So the next step now is, when you have to make an incision, make a partial incision. So this partial incision makes you go through with a microforceps and with a viscocohesive, so that there is no sudden decrease of pressure inside the anterior chamber. Next is, if the anterior chamber depth by any means is more than 2.3 millimeter in my practice, we are all talking about initiating the rhexis. I believe that you have to give a direction to the rhexis initiation, because if you give a linear initiation, that can create a situation wherein it can extend right up to the periphery. So a central curved initiation is very important. So that helps. Next, what we have started doing nowadays is the reversed angled initiation. This reversed angled initiation helps you in the sense, once you make that reverse angled initiation, it comes directly under your view. Even if you have to struggle, since it's directly under your view, the flap will not extend to the periphery. It will not have a predisposition to extend to the periphery. So this is another thing which we note to do. You will see the bouncing. This bouncing shows that there's a lot of intralenticular pressure which needs to be taken care of. Next part is, we have taken care of the central part. So this part has a high intralenticular pressure. The next thing which we do is, as Chi says, you do the milking. So from the periphery. And the next step is, once you have done the milking, you have to do debulking to take care of the posterior compartment. So let's see how it is being done. So once you introduce that, so this is the milking which is being done, which takes care of the high intralenticular pressure which is there in the mid periphery. You can see how it is coming to the center. So that takes care of the high intralenticular pressure. Once that is done, you can go ahead, push it slightly so that the fluid gushes it from the posterior compartment into the anterior compartment. Once that is done, the capsular access becomes simple and you can very well continue as if it's a normal case without any problem whatsoever. So you'll see how the capsular access is being completed in a normal fashion. So this done. Next is, you can use the YAG laser anterior capsulotomy or the puncture also for that matter. So some pearls which we need to take care of, you'll see how it is trying to extend. So this is the place where you have to inject the visco so that it gets closed, it doesn't extend. Had you injected it there, it would have extended to the periphery. So that is what needs to be taken care of. So in this video, I would like you to see, you will find that there are 4 problems which are there, which are causing it to extend. First, it's a viscodispersive, large incision. You see how I'm pressing it. So this pressure on the anterior capsule is also very important. You should have a pointed tip also and a micro-calibrated forceps. So once at times, the Argentinian flag sign, despite everything, it still occurs. So a small thing, this flap motility sign, if you find that the flap is everted and fluttering, you will see that triple view stain. It means it is pre-equatorial. And if it becomes inverted, it means it is post-equatorial. So in that case, you have to extend, you have to convert. If you don't convert, you will end up with a nucleus drop. With this, you can implant the IOL in the bag if the flap is fluttering and everted. Flax is something which is also there. You'll find in these intumescent cataracts, you'll see a volcanic eruption. In this, video, you have to trypan blue stain it, and because there are bridges around, so you have to move in a more diligent way. In these white cataracts, despite everything, you feel that you will find that there is partial fragmentation. So this makes phacoemulsification very easy all the way. So this is a fibrotic cataract with subcapsular plaque. So in these subcapsular plaques which appear in white cataracts, you have to be very careful. So what the scheme of things is that you create an opening in the central part, central to the plaque, and you complete the rexis central to it. Once that is completed, by all means, then comes the second part. Second part is you have to, with dissection, you have to separate the subcapsular plaque. So you'll see how the subcapsular plaque has to be separated. This is basically Deepak Magur's idea, and he showed it in a beautiful video in ESCRS, which won the prize in our AIOS also. You have to totally dissect it from all sides. Once you dissect it from all sides, then you can free it. And once you can free it, you'll find that I'm still struggling to separate it. You'll see that still the subcapsular plaque is not fully separated. So separate it fully. You'll see how it's separated. You have to wait. Once you find that it is properly separated, that is the time when you can further go in and take out the subcapsular plaque. Once that subcapsular plaque is taken out, the capsular access can be completed and the procedure completed without any problem. So that's what it is. So this is another one. I think I should hold it because in this, the cleavage plane has to be created to, so once this small rexis is over, the cleavage plane is created. So this cleavage plane, once created, you have to go around and then you have to dissect it. I'm not showing the dissection because I showed it extensively in the last video. So, you have to just wriggle it out and separate it so that you end up with a situation wherein you have that central plaque out, the subcapsular plaque out, and then the capsular access can be completed. Thank you very much for your kind attention.
Thank you, Dr. Rohit, for those amazing, fantastic tips that you shared with all of us on the intumescent cataracts. I have a question for Dr. George Baiko, who's one of our panelists all the way from Canada. And George, how do you would you do anything differently for the intumescent cataracts than what Dr. Rohit said? Would you like to add any pearls on that? Like he showed some amazing tips.
I think he's covered the subject quite well. But I think the one thing that I do that's a little bit different than what he does is once I have my capsule rexus, rather than use a tip to milk the liquid from the mid-periphery or from behind, I'll introduce my phaco tip into the anterior chamber and just push the nucleus back and forth gently to get that fluid to come forward and aspirate it out with my phaco tip. So I'll get the fluid out that way. I'm not sure which technique is better. I think the goal is to get the fluid and to get that pressure down, and whether you milk it or whether you blot it as I'm doing, I think we both accomplish the same thing. I think the important thing is just to be gentle. The other point is in that subcapsular plaque that he was just showing us, I've had situations where I've had that, and your initial reaction is to go in and you try and see if you can use the phaco tip to remove that plaque, and it doesn't even touch it. So I think that was very important that he showed that you have to remove that manually before you go in and do your phacoemulsification. So I think it's a very important point.
Thanks, George. In fact, when I was seeing him do that milking, I was like very, I was scared that he might just break the capsule. So is there a special instrument that you use for that, Dr. Rohit, to stroke it? Because, I would be worried in an intumescent cataract, trying to stroke it with any kind of instrument, it might just break the capsule.
I think it's the normal, the one which, what do you call it, the cannula which I use. We should not be very much worried about, this anterior capsule in intumescent cataract, because this has the same thickness as it is there in the normal cataracts. So don't be overly, protective about the, anterior capsule, because even if you do it, stroke it, it will not, because when you're doing it, you are not creating a pressure. With that pressure, the fluid is being directed towards the center. So it will not make any difference whatsoever.
Right, thanks. So in the hands of a master surgeon, I think he knows exactly how much pressure he's using and everything. Dr. Dhami, sir, you have been, your center has innovated for intumescent cataracts, and you've published on OCT use for intumescent. Can you share quickly?
Yeah, Rohit, very well demonstrated. But we as you see on the anterior segment OCT, you do get pockets, and you can really realize how many pockets are behind the nucleus of the fluid. And like Dr. Beaker said, it's just rocking the nucleus to break those pockets, and immediately the fluid will be grasping out, and you have a complete flat anterior capsule on back to the nucleus.
Great, thanks, sir. So the OCT is quite an innovative thing on the femtosecond platform, as well as standalone. Before you do the surgery, you can do the OCT to check these pockets, as Abhinav Dhami has described. And before we go on, I think I'll take Deepak Megur, who's who had these award-winning films. And would you like to chip in with few pearls for these fibrotic cataracts and how you remove those things from under the capsule? Deepak, are you there? I think I don't see Deepak there. I'll take.
I just want to make one comment.
Yes, Dr. Namrata, yes.
So I was saying what Dr. Dhami sir has said, I think makes a real sense if you see it on an intraop OCT microscope, and I think I've said that earlier also. And I do have videos of what Dr. Rohit Om Prakash is saying, that if you actually make a small rexus first, you can actually see the release of the fluid, which is much more controlled, as opposed to if you have an Argentinian flap and it just kind of gushes out, which is more abrupt. So you can actually visualize it there. And if you see those black areas in the center of your white cataract on the intraop OCT microscope, then you know that it is not going to, the fluid is not going to come out, which I think Dr. Dhami sir is also pointing towards. But if you don't have that, then you know that it is definitely going to come out.
Yeah, I'm there. Am I audible? Am I audible?
Yes, Deepak. Just for a moment, I'm going to ask you something.
Then it makes sense, to do a small rexus and then to make a big one, because of the controlled way the intraventricular pressure is released, as opposed to the abrupt way it would otherwise.
Thanks, Namrata. In fact, we'll look forward in case at the end of the show, if you have that video with you, we'll see for a few seconds. Not right now, but like if we have time at the end of the program, we can do that. And Deepak, we were missing you. Dr. Deepak Megur has, as Dr. Rohit said, shown amazing videos. So I don't know whether you saw Dr. Rohit. You were missing for a while. So did you manage to see Dr. Rohit Prakash's last case where he showed those, how to remove those subcapsular fibrotic membrane? So I was going to ask you for any pearl because we are running short of time, and then we quickly go on to the next presentation. So would you like to chip in with any one or two pearls that you might want to share with our viewers? Deepak, Dr. Deepak Megur, can you hear me? I think he can't hear me. Anyway, so I think we'll come back to him later.
Gaurav, can I just have a very brief comment?
Yes,
I find Greischeber small scissors to cut these fibrotic plaques from different ergonomically suited small incisions, very useful. And the two-stage capsulotomy and rexis were suggested by Dr. Gimbel in early 90s. So I think,
I think those are amazing.
Rohit made a great teaching videos. Thank you, Rohit.
And I agree with you completely. I do use these micro scissors myself as well. Dr. Rohit, you wanted to say something?
Yeah, Lisa wants to say something.
Sure, ma'am.
Thank you. Just briefly, I think this is the one valid reason for using Healon 5 if you have that accessible, because the whole point is just to have the pressure in the chamber greater than the pressure in the lens. And so when you make a small opening and you continue and you have that nicely filled, you see a very slow egress of fluid, and it's another approach.
Excellent tips, Dr. Lisa. And yes, John, you wanted to chip in. Yeah, quick one, last one. Yeah.
Yeah, just real quick, the idea of keeping the pressure higher in the anterior chamber is really important. There was actually a video at the ASCRS where somebody used an anterior chamber maintainer and worked through small incisions so that the pressure inside the anterior chamber was always higher. Instead of using a viscoelastic or anything else, really inexpensive, really easy way to get around the Argentine flag sign. So that's something to consider.
Thanks, John. That's a nice tip as well. And for me, the take home was closed chamber, enter from a paracentesis at the limbus. That's what I like to do. And I saw Dr. Rohit do that as well. For me, that makes sure that the chamber is nice and tight. But all these things can be useful, and Dr. Lisa's tips. So I think, so that we don't fall behind time, I'll go on to invite our next speaker. And none other than Dr. Abhay Vasavada, whom I'm sure everybody in India and abroad knows. He's been one of the pioneers. He's been the face of Indian ophthalmology all over the world. And an introduction for him is very difficult to make. Yet I would like to chip in with a few things. He was only the second Asian to be awarded the Binghorst Medal Lecture by the ASCRS in 2011. He is on the power list of global ophthalmology, which is like one of the biggest lists, and there are very few Indians there. He's one of them. He was awarded the B.C. Roy Award, which is given, it's an award given by the Indian government. It's one of the most coveted awards, not given only to ophthalmologists, but from across the spectrum of medical specialists. So getting this is really a big honor. He also had the American Academy of Ophthalmology's Achievement Award in 2005. More than all these things, he's been a great teacher to all of us with all his pearls about pediatric cataracts and everything. Now, I won't hold him back anymore.
Thank you.
Dr. Vasavada, sir, please go ahead.
Thank you, Gaurav. So nice, so kind. This is my financial interest, and I recognize the contribution of my team on this topic, restoring the capsulozonular complex in advanced chronic angle closure glaucoma. And angle closure glaucoma typically has a narrow anterior segment, and there is very little rotation of the ciliary body in a typical angle closure situation. As you would see here, the ciliary body has very well in a normal orientation, and therefore conventional cataract surgery, putting a lens in the back, works very well most of the time. However, if the chronic angle closure process is advanced, there is an additional element of the anatomy change, and that is the forward rotation of the ciliary body. And this can be measured now very precisely, the anterior rotation of the ciliary body, and that can give you an indication of the severity of the narrowness of this anterior segment. Now, there is a total forward bulge, and if you put in such an eye in the bag, conventional IOL, sometimes it doesn't work. And this didn't work in my first eye of a patient where the entire IOL remained forward like the original cataract, and the angle was very small, and I really had to repeat a procedure. Now we believe that this forward rotation is because of the lack of zonular and capsular back support of this lens, which could both the ciliary body rotation or a primary event. And I recognize Dr. Kumar Doctor here, who really made an award-winning video this time in ASCRS on zonular and zonulopathy. It's the capsular zonular weakness which rotates the ciliary body, we believe, and leads to this possibility of malignant glaucoma and continuous of the shallow chamber. So I think thinking out of the bag it's very important now. And at this stage, I would like to acknowledge the contribution of Dr. Tobias Noyan, Dr. Gimbel, Dr. Lisa Arbieser, Rupert, Jason, Thomas Utting, Mary Jose, and many others who have really worked on these thinking out of the bag. What it means is that putting the lens outside the bag or supporting the lens outside the bag, that means putting the haptic on the front of the anterior capsule after creating about 4 to 4.5 millimeter posterior capsular axis just underneath the iris in front of the anterior capsule, and then capturing this optic through both anterior and posterior capsular axis. So the haptic actually supported at the ciliary sulcus and giving a great stability to the entire IOL. And the IOL is actually locked between the two fused anterior capsule, which is an additional advantage of preventing central posterior capsule axis. So this second eye of that patient, where we had a problem in the first eye, I did this technique, doing a axis, placing the haptic in front of the anterior capsule, and then capturing through both the anterior capsular axis. This technique is a little difficult, but like many of these newer techniques, if you focus on it and pass through learning curve, it's not that difficult. It's very easily reproducible, and this is a typical scenario where you can see the IOL sitting behind and the very nice open angle with a great distance between the uveal tissue and the IOL. And the same patient preoperatively, if you see the anteriorly rotated ciliary body versus the post-op, which is now a different anatomy. So in other words, the possibility of malignant glaucoma or a persistence of the narrowness of the anterior segment following cataract surgery is easily avoidable or avoided time after time in this situation. You can see the rotation of the ciliary body anteriorly now going back here, a lot of space here, and you can demonstrate in all the imaging technology convincingly the space created. But the best part is that here the IOL and the capsular bag complex is actually supported by the haptics in the ciliary sulcus. So you don't need to depend on the loose capsular bag zonule complex. This is different than putting the entire three-piece lens in the sulcus, which is a conventional way of doing it, and we have done many. We repented it several times by putting single-piece Acrysoft and many others. But here, opposed to that, here because of that angulation and the posterior pressure exerted, the fused capsules lock the lens and really create a very safe distance with very stable IOL in that situation. Dr. Samresh Srivastava, my colleague, has demonstrated it in a Miyake view, how stable these captured optic with both the axis and haptics and sulcus remain after the surgery. So I think we need to change our perspective in thinking out of the bag. And once again, I salute my senior faculty and colleagues from whom we have learned all throughout. But this technique is not that difficult to perform. particularly if you have a long-standing advanced angle closure glaucoma, you can rest assured you will not have a malignant glaucoma or any change, persistent change in the shallow chamber. You will always restore it, and I would recommend for your consideration this concept and this approach, which is nothing new, but it is one more application of this wonderful concept of capturing through both rexes with haptics and ciliary sulcus. Thank you for your patient hearing.
Thanks, Dr. Vasavada sir, for that fantastic presentation. And we do remember the nice award-winning videos on the optic capture. I have a quick question for the panelists after this, but first one question from you. And in these angle closure or chronic long-standing, narrow angle glaucomas, would you also find any difficulty in doing a primary posterior rexis and maybe expect some kind of vitreous disturbance more often than not? And would it be really so important to do the posterior rexis rather to just do a posterior capture of the anterior capsule? This is just a thought, and I'm sure you have a
No, I think this is very, very relevant and very, very useful thing. I think I did 7 cases so far. In the first case, I had to abandon because I did it in a topical. So you need a controlled peribulbar anesthesia. And once you have the control, the anterior vitreous disruption or disturbance is practically non-existent. But if you only capture through anterior capsule in such angle closure, it still will be the same, because what we really need is the pressure of this angulated concept on both this capsule, but importantly on the zonules, so that it mechanically will push and it will work like a debulking of the antivitreous, as you will find in anti-vitrectomy for malignant glaucoma. It does the same trick like a vitrectomy of a bulking by pressurizing it, but without doing anti-vitrectomy.
Fantastic.
I have a question for Dr. Vasavada, Gaurav.
Yes,
I remember when you had described this technique for optic capture in pediatric cataract cases, and there it was done with and without anterior vitrectomy. You said that the reaction is more in the anterior chamber. The AC reaction was more in those cases where capture was done vis-a-vis where capture was not done. So do you think that it is still, does it still hold true in cases of adults when you're doing it for angle closure glaucoma?
I think what you're referring is correct. We did publish that, but later on we realized that it is IOL design and material dependent and the size of the rexes. So we then published a report where we did not find increased inflammation. But your point is correct, Professor Namrata. It can happen. So if you have a good viscoelastic closed chamber technique and all the principles which we are learning from our stalwarts, that's not an issue, I believe.
Thanks.
Even in this scenario.
Thank you, sir. I have 2 quick comments from 2 panelists, and then I'll hand over to Dr. Rohit for the next speaker. I see that Josh Young has been wanting to say something, and he's something crossed his mind, and I'll ask him, and then I'm going to ask Dr. Rajendra Prasad to chip in before we go on to the next talk. So please be ready to Prasad.
Yeah, can you hear me? Yes,
yes,
because I don't think it okay. So first of all, that was an absolutely beautiful video. It was really wonderful. I am much less experienced than I suspect that some of you guys are with doing posterior capsulorhexis, and I want to follow on the question that Gaurav just asked. In the event that I want to simply do capture through a very conservative anterior capsulorhexis without violating the posterior capsule, is there any sense in putting in a capsular tension ring to put the posterior capsule on greater stretch, sort of like a drum head, so that I have a larger diaphragm to push posteriorly?
I don't think so. The capsule ring will stretch the posterior capsule, as you said, and will remove the posterior capsule striae. But what we are looking for is a push or a pressure on the entire bag capsule zonule complex, both the capsule, the anterior, the equatorial, the posterior, and the zonular complex. So I think anti-capsule capture will have some impact, but really I would think this is not the best thing.
Thanks, sir. And a quick comment from Dr. Prasad, and then I have a question for all the panelists for one quick one. Yes. Dr. Rajendra Prasad, you have to unmute yourself, please. Yes, please. Yeah.
It was an excellent presentation from Dr. Vasavada, because no doubt beautiful presentation. I have just a very small comment. Like, since the whole iris lens and the zonular diaphragm was forward in your first case, what you showed. So is there any possibility of doing the posterior decompression? Because it could be the vitreous which is pushing them forward. So why not to do the vitreous decompression by doing a partial anterior vitrectomy from the pars plana route or so?
I think it's a very good, valid option, and I've done it in past. But with this, you can get away with the vitrectomy. The whole idea is that you don't need vitrectomy if that happens, and you can avoid the consequences of anti-vitrectomy and disturbance. But your point is correct, and I accept that.
That was a wonderful point, Dr. Prasad. So I think we're going to go on, but before we go on, okay, Partha, very quick one, and then I have okay, and then George wants to say something. Okay, Partha.
Vasudha sir, excellent video and an excellent concept that you have floated. So one question that I would like to ask is, did you study the angle of the anterior chamber after doing the in the post-operative view? Meaning, because these are angle closure glaucomas and which are chronic, so the amount of adhesion that would have taken place would persist, would it not? I mean,
yes, yes. I think that's very true. You're right. We have been following with all imaging technology possible, including the angle examination or gonioscopy, anterior segment OCT, UBM, all the stuff. The actual plastering of that real very fine angle will not change. So depending upon the function of the trabecular meshwork now, the IOP will then, but 8 or more up of the 10 cases, it works well. But you're right, it can never actually reopen that cemented peripheral syneque.
Yes. Thanks, Dr. Vasavada. George, quick one, and then Dr. Rohit takes over.
I just want to follow on what Dr. Partha said. I have a fantastic video. If you look at your UBMs, you can see that the whole bag IOL complex goes back, but the iris still seems to be anterior and blocking the angle. So my approach to these cases is not only to remove the cataract and put the IOL and have that complex go back, but to address the angle. So I'll do a goniosynechial lysis, and then I'll also do a pupiloplasty because that iris is very flaccid. It's lost all of its, usually it's lost all of its musculature, and if you don't do a pupiloplasty, it'll come back up. So do you have any comments about that, whether or not you address that?
George, that's a very good thing, and I would definitely consider, but so far of the cases I did 7, I didn't need to do that. IOP remained quite within control, sometimes with the drops, sometimes without it. But definitely pupilloplasty, mechanical stretching out would do. But even if you open up the angle, the key is the function. What we are talking is the functioning. You may open anatomically angle, but is it going to function to drain? That's the question. So I don't think pupilloplasty and all these things would work in this such an advanced situation that we are referring to. But I would consider that definitely. That's a great point.
Thanks, Dr. Vasavada. Dr. Rohit sir, I think we should go ahead with the next one.
Well, I have the honor of calling over Lisa Arbizer, who is basically one of the best teachers for complex phacosurgeries, and in the peer voted CRST1, she was the top 50. Hello, can you hear me?
Yes, we can hear you.
She was the top 50 opinion leaders in cataract surgery, and she got the Innovators in Premium Lens Surgery Worldwide Award. So she and Ame they formed an ophthalmological couple and formed a unique way of retiring in 2013. I have heard so many instruction courses of hers, and I'm a great fan of hers. She would be speaking on PCR, what next?
I'd like to say what an honor it is to be included, and very difficult to follow my incredible friend and mentors, particularly Dr. Vasavada, and I'm almost cheerful that you've taken this concept, you know, which I've been pushing since about 2015, and really realize the true, you know, at least one of the values of it. So I'd like to just go ahead with my slideshow, and I have voiced over a lot of it, so hopefully it will go very smoothly. I have no relevant financial declaration to make. So when we have a PCR and we break the capsule, the key is to recognize it as soon as possible to limit damage. And then additionally, what our goal is to avoid a catastrophic complication later, and outcomes is to avoid intraoperative vitreous traction, prevent postoperative vitreous traction, and maintain a normal tensive globe as much as possible throughout the procedure. Just because we broke a capsule doesn't mean that we need to have collateral damage of cornea, iris, or capsule. And I'm particularly anxious to recommend against relaxing capsule. If we need to get something forward, then enlarge it rather than make cuts, because the capsule can be so valuable to keep an implant in its perfect position later on. We're limiting the stage of complications, and I think it's our goal to leave a clean anterior segment, not necessarily to deal with any lens material that falls below into the posterior segment, but rather to do anything we can to get it out of the posterior chamber into the anterior chamber to remove it. And once it's there, at least in the U.S., at least where there's available retinal three-port vitrectomy and lensectomy, I think it's important to leave it. Our goal would be to implant preferably a stable acrylic lens, but better to leave it aphakic than to end up with a cloudy cornea that where we can't follow the retina.
Don't blink or you'll miss subtle signs. You'll see in a moment the spidering of the back capsule despite protecting that capsule for the last fragment right there. And that tells us that the likelihood is we've ruptured our capsule. We need to not withdraw our phaco instrument but exchange the chopper. Don't blink or you'll miss subtle signs.
Okay, so
this typical cataract with toric implant is going in an unremarkable manner. I'm protecting the posterior capsule with my second-hand instrument, supporting the chamber as I always do with BSS while removing the instruments from the eye. And that was fortunate because I now see a strangely clear area in the posterior capsule, and on testing it I see that viscoat will drop right through, indicating that in fact I have a round punched out hole in the posterior capsule. Thinking fast, I'm using viscoelastic and the sulcus to flatten the anterior and posterior capsules to create a safe posterior capsular rhexis. We must find a little tag or make one if necessary with a scissor so that we can make a true rhexis which finishes outside of where it begins. No matter how round your punched out hole will look, it is at risk for expanding with any pressure, as it will not behave as a true created continuous rhexis will. The vector force has to be more centripetal for this very thin elastic tissue, and we will successfully complete this. That's much more difficult in the face of a ruptured anterior hyaloid, but fortunately we kept the chamber from collapsing on removing both the phaco and INA tips, and so the hyaloid never broke in this case, permitting us to go on with a completely uncomplicated case. Now that we've accomplished that, we can fill the bag and feel safe to place our toric implant. Pressure on that posterior capsule will not extend the tear because we have a true rhexis. When we go to remove our viscoelastic, we must keep in mind that we need this hole to be nicely tamponaded, holding the lens back if necessary with a second instrument while removing viscoelastic and placing Myocol in the eye prior to removing the instrument to allow prevent any vitreous prolapse.
This is amongst the saddest of situations, what ought to be a routine case, but you'll see that the rise time and vacuum are too high for this unpredicted, soft myopic lens. I'm removing anterior cortex in the usual manner and planning a vertical chop technique. As I just begin to start to come through the anterior nucleus, you'll see that tremendous change in pupil bounce, and what happened was the material came sucking through the port, bringing the posterior capsule up to the phaco needle, and we have a rupture. That tremendous change in anterior chamber depth and bounce and pupil size is a surefire sign of complication, and you'll begin to see my adrenaline surge as I replace the chopper for a dispersive viscoelastic cannula and fill the anterior chamber with viscoelastic while holding my ground with the phaco tip in place to prevent lowering the pressure and losing the chamber. Only now, when we control the chamber, can we come out, inspect, relax, and plan.
Direct entry, measure 3.5 millimeters back to find the pars plana. Perpendicular to the sclera, make sure you see the point of the MBR blade in the pupil to be sure you're through and through. This is an old 20 gauge, so it's slightly larger for the flat edge. And then always watch the port while accomplishing this. We must have a plug or a temporary tie suture, and always suture this. We have to be sure there's no incarceration of vitreous. Next, we're going to see that we're going to do a trocar system insertion, and we're going to pull the conj so it's not coincident. We're going to go 3.5 millimeters back, limbus parallel to make a scleral tunnel. The appropriate angle is 30 degrees to the sclera, and then enter completely. And you'll see that the here it's a little extreme, that the collar pops backwards, so that we're sure we have not broken the ceiling or the floor of the scleral tunnel, so that when we come out we can apply direct pressure. And I'm told that it's preferable, rather than the pressure that I've applied here, to actually crush it with the tip of the trocar in order to be sure that there is no incarceration of vitreous. This should seal nicely without any bleb. Here we're going to see that we can only apply the trocar when we know that we have a firm eye, because you can see the kind of pressure it takes. And I'm showing this Miyake modified view that Liliana Werner helped me with in order to demonstrate the pressure, and also to show in your mind's eye what's happening inside. And the pars plana, you can see how it tilted backwards because we had a really good scleral tunnel, and then when we bring the vitrector through the cannula, it comes through again. Now this is a regular 3-port vitrectomy, and it's just an endoscopic view of this 23 gauge incision that was made directly, and you'll be able to see that the reason that it's absolutely critical we have a scleral tunnel incision if we're not going to suture, if we want to be transconjunctival, is that here in this complete vitrectomy you can see the kind of gaping hole that is there, and we would be filling that with vitreous rather.
This is an aphakic patient with a planned anterior chamber lens, and there's vitreous preoperatively in the anterior chamber, which we're identifying with washed Kenalog. As we remove the cannula from the paracentesis, you can see the vitreous follow the gradient of low pressure. When we cut it at the incision site, there's no real traction. However, you can very visibly see why we don't recommend sweeping the incision any longer, because you can see the tremendous tractional forces that are occurring through the pupil with this maneuver. We've made a pars plana incision, and we've inserted our bare vitrector needle through that incision, and we're now placing a 23 gauge irrigating cannula through the paracentesis. We're going to begin cutting, and in a moment you'll see we're going to go down into foot position 3 where we activate vacuum, and you'll begin to see the vitreous move. We're not being overly efficient, and so we're putting the vacuum up just a little bit in order to begin to get some movement, and pretty soon you'll see the vitreous very efficiently come home to the posterior chamber. If we were doing this through the anterior chamber, we'd be allowing the gradient of pressure to be lower anteriorly than posteriorly, but here the low pressure is going to be posterior, and so we can be very effective.
This is a modified Miyake view, and we're doing an anterior vitrectomy. That's with a clear corneal incision, and despite the fact that I'm putting the vitrector through the rent in the posterior capsule, you can see that as much vitreous is coming forward from the vitreous body as what I am removing anteriorly. And as we withdraw, there's often a wisp to the incision, as you might see at the slit lamp the next day. Now we're going to intentionally break the capsule and plan a posterior incision through the pars plana. And Kenalog or Triessence is particulate identifying, and the moment we pull out with our other instrument, you can see that vitreous followed. And now we're going to go through the pars plana, still with irrigation anteriorly, but pars plana below. We've amputated our anterior posterior attachments. On the one side, it actually removed the vitreous from the incision. On the other, you can see there's no traction when we go to sweep it from the wound because there's no further attachment.
So here's just the preference of always optic capturing, which is why one should never relax the anterior capsule and always pay attention to the size of your capsulorhexis. Here is just the standard anterior capture. If you were to break the capsule while you had a one-piece lens in the bag, you could do a reverse optic capture as long as the optics remain in the bag. Most patients will not have any pigment dispersion, although you need to watch them because once in a while they'll need a PI after you do a reverse optic capture. If we didn't have an intact anterior rhexis, then I would make an intentional posterior capsulorhexis so long as zonules were intact and capture through the posterior capsule. And another option, when we have poor zonules and we have an opening in the front and the back, if the zonular laxity is not great, then we can actually buy capsulotomy capture as Dr. Vasavada showed you earlier in the case of angle closure. So post-op care is so critical. I believe that we should absolutely always use moxifloxacin intracamerally. I did that from following Steve Arshinoff's recommendations after the ESCRS study from 2007 on in all routine cases. But certainly when we break the capsule, we have an 18 times greater risk of endophthalmitis, and I think it is absolutely required, though off-label. It was my habit, if I knew I was going to deal with vitreous ahead of time, to give one prophylactic dose, PO, of Avalox, which is moxifloxacin, in order to cross the blood-brain barrier and have an MIC in the vitreous at the time of entering the eye, but otherwise I would give one dose postoperatively. There's no real evidence that this is effective, but at least in my experience anecdotally, I've never seen an endophthalmitis after breaking a capsule using that technique. We want to warn patients about floaters and educate them for retinal symptoms. I might add that there's now a Zhang ring test, which is through Precision Vision, which I have no financial interest in. It's like an Amsler grid for the macula, but it actually is a piece of paper you can give your patient, and they can pick up a peripheral detachment. We want to prophylax and treat pressure spikes. Better to leave more OVD alone in the eye, especially if it's not Helin 5, which I would never use in a complicated situation, and prophylax than to be aggressive taking it out and allow vitreous to come forward again. Timely referral to a retinal surgeon for any retained nucleus and a good scleral indented retinal exam, especially if we're doing a one-port pars plana incision. We want to be sure that we don't have any tears around the port because of allowing any vitreous herniation into the wound, and then post-operative traction and aggressive anti-inflammatory management with CME. I think disclosure to patients is always important. So I thank you for your attention, and I've tried to collapse a 2-hour course, which is my preference for the time of this subject, into this small time. Thank you so much for the invitation too.
Thanks, Lisa. Well, you know, most of the, this is a question directed towards Dr. Mahipal Sachdev. You know, most of the anterior segment surgeons who are doing phacoemulsification are not fully conversant with the posterior vitrectomy. Dr. Abhay has shown with his presentations that the posterior vitrectomy is a much better one, which doesn't cause the extension of the posterior capsule rupture. But how do you think it is relevant for an anterior segment surgeon who is not into any posterior segment vitrectomies? Should he continue with the anterior, or should he shift on to the posterior vitrectomy? Dr. Mahipal, sir.
Well, Rohit, the question that you have asked is ideally there are several studies, and I think Abhay was a pioneer, and as Dr. Lisa has also just shown, for a better clear up and for the rent to not extend, it is always better that you go ahead with a posterior approach. As also prophylactically, you can do that, like I've been showing in cases where there are subluxation, etc. But obviously, in case a anterior segment surgeon does not have the proficiency, and it is better that you do not cause the complications by trying to do something that you do not know how to do. Ideally, one should learn it. If a person is not able to learn it, you have to clear up the anterior chamber and the wound, etc., and the use of triamcinolone there. And also, normally when we, as in our phaco machines, we have full function probes. So it is still better to go on to a bimanual rather than a full function anterior vitrectomy probe. So best is to switch on to posterior. Otherwise, if there is a small amount of disturbance of the vitreous, you can actually tamponade the posterior capsular rupture, and with a good viscoelastic, and then go ahead and do the vitrectomy using anterior segment vitrectomy and triamcinolone. So that is something very, very, it's not that anterior root vitrectomy is out, but it is definitely posterior is pars plana root is much better. So I think depends on the surgeon's confidence levels.
I would have to agree, and that's why we have skills transfer labs, and also there are wonderful devices. I have no financial interest, but such as Stuart Stahl's Simuli, which we've been using, and I recommend that this is something that one practice before you're in the acute situation, of course. Good point. Thank you.
Dr. Deepak, your take on this? Are you there, Dr. Deepak Megur?
I'm having trouble not sharing my screen.
I'm here. Yeah, I'm here. Dr. Rohit, am I audible?
Yeah, absolutely. Please go ahead.
Dr. Lisa, congratulations and thank you for teaching us PCR management anterior vitrectomy for years now. We have attended your courses. They're all wonderful. Just to add to a comment with Dr. Rohit was asking, like what to do with anterior vitrectomy through the anterior route. Well, I think one point I would like to highlight here is that maintaining a low bottle height when you're trying to do an anterior vitrectomy is extremely critical, because if you're not done a PCC still, and if you already injected viscoelastic and you go in with an infusion which is 90, which you already kept for your phaco, and if you go in with that, it is going to blow out the posterior capsule. It's going to enlarge the posterior capsule. So one way to prevent enlargement of posterior capsule before doing Rexis PCC would be to ensure that the dynamics in the antechamber are very well maintained. And for that, I think monitoring your bottle height is extremely critical. Get down the bottle height because your dispersive OVD is still there. Then do remove the anterior vitreous and then do a CCC, and then you can go ahead and implant the lens. Because if you don't do a PCC when you're implanting the lens, again, you're more likely to enlarge the PCC.
I think, Dr. Deepak, your point is well taken. The only thing that I wish to say is that most of the new machines, the moment you switch on to the vitrectomy mode, they will automatically bring down the bottle height. So the new machines have already taken care of that. But in case you have an older machine, obviously you have to do. And I would 110% agree with what you have said, that the dynamics need to change when you're doing a vitrectomy over what they were when you're doing an IA or a phaco.
And I just like to add, it's a very important part, but you need the highest cut rate you can possibly get. I mean, there's so much more to discuss. Highest cut rate, the lowest, if you have a peristaltic machine, just a low AFR, 15 to 20. And then we want to balance our bottle or our infusion with our vacuum. So I like to tell people to have a panel set vacuum, go pedal to the metal, and then balance their vacuum so the eye is normotensive when you feel it. That's so much more to discuss on that, but it is very important to keep that eye never becoming a prune. So if you pedal to the metal on your AVIT, and the eye gets soft because your bottle's so low, that's bad too. So that balance has to be achieved.
John, your take on this? John Hart? John, are you there?
Yeah, I'm here. No, Lisa did a fantastic job.
Segment surgeon, for that matter.
Yeah, I thought Lisa did a fantastic job. I think one of the things that we take home is, yeah, many anterior segment surgeons are not going to be comfortable doing pars plana vitrectomies. I think those days should be gone. I think we should learn to do them and learn them properly. Again, there are a lot of skills transfers courses, and I think as much as possible we should do those. It's so much easier to bring the vitreous back where it belongs than to try and cut it off so it falls back into the anterior chamber.
Dr. Vasavada has a beautiful video that shows that with a ball of yarn from, I don't know what year that was, maybe 2017, AFCRS, something like that. Yeah, and I use that clip in my, thanks to him, in my lectures all the time. And you will enlarge your opening. You miss the opportunity to convert to a capsulorhexis if you go in an anterior approach. Even if you go through that incision, through the opening in the PCR, you will bring vitreous forward as well as back, and always enlarge that capsule range.
Can I have one comment? I think the goal for a cataract surgeon is not to prevent drop of the nucleus or salvaging where to put the IOL. The one first goal, as Lisa mentioned, prevent acute intraoperative vitreoretinal traction, injury to the interface. And that happens whenever vitreous prolapses or do vitrectomy. Much more so when you do anterior vitrectomy compared to pars plana. So I think, as John and Lisa and everybody agrees, we need to learn. The cataract surgeon now has to change the mindset and somehow get in on top of this by attending courses and whatever.
Yeah, I think that's the take-home or in-home message nowadays, for all that matter. So PCR, what next? Now we have the prince of ophthalmology, Dr. Ashwin Agarwal, who would be talking about Plan A to Plan B. Over to Ashwin.
Thank you so much, sir. But Prince, really, I mean, I don't think I deserve those comments, but I will start my presentation. I hope my screen is clear to everybody, and I'm audible as well.
Yes.
Okay. So I think the Plan A to Plan B was a concept which Dr. Rohit was talking to me about, and said, you know, we should teach people how to do this. When they have problems on table, everybody panics and worries what to do and how to do it. So just taking them through the steps and what are the instruments that probably are required is a very important element of this. So let's talk about Plan A. Just to take things into perspective, Plan A over here basically is, I'm showing you Plan A of what I do in subluxated cases, because my case of Plan B is also a subluxated case. So I'm just showing you what I do. After doing the rhexis, and I think Dr. Chi showed some beautiful videos. I wish, as Dr. Rohit said, I could do magical wonders like that. But no, anyways, we're mere mortals. I use a paperclip hook, which was designed by Dr. Susan, and wanted to just showcase this because this is not the actual video. I'll come to that. But what I'm doing here is stabilizing the bag before I actually start my phaco. And this is the paperclip hook which goes into the tunnel like a Gabor Chariot's tunnel under a flap. And now the bag is pretty stable. I always put a capsule tension ring because the equator is not stable over here, and it always allows some amount of vitreous. The capsular hooks as well as paperclip hook along with the CTR really holds this whole capsule at bay and pushes the vitreous behind, and this allows the vitreous to come forward. I'm able to complete my phaco as well as irrigation aspiration over here. And once this is done, I'm pretty much placing the lens in the bag, no issues. And that paperclip hook is now not removed. That's the only one that I really need in place, and it's always going to be permanently stabilized over there. It doesn't need to be coming out. I use this mostly in traumatic conditions, not in the progressive ones. And this is the day 1 post-op of the same patient. This is not my video, which I'm going to show you today. The video, the presentation that I have in mind for you guys is this: the instruments that you need if in case any of the steps before I showed you goes wrong. And I'll show you that as well. But these are the instruments that you need. A basic vitrectomy setup with a 23 gauge needle, gluteal marker, a gluteal forceps, Trocar AC maintainer, a 3-piece lens, and fibrin, glue or sutures. A lot of times gluteal can be a misnomer. You can put sutures, no harm in it. So here's the problem. So it's the same type of case where you have a subluxation. I mean, it doesn't really show when you started off, but the minute I put this needle in, and all of us here would have faced this initially, doesn't look like it's such a big issue, but when you go inside, this bag starts dangling a little bit. So you want to really stabilize this after doing a capsular excess. You really want to stabilize it. I'm just taking it forward just for in interest of time. I don't want there to be a delay. I want to show you guys what really to do if in case a problem like this arises. So I'm doing my hydrodissection and I'm going through the motions as it is. I'm also doing a hydrodelineation so to ensure the cleavage is very clean and simple. Once I'm done with, once I'm removing it, you can watch here very clearly what's happening. I, by accident, and this can happen to anybody, while doing, and there we go. So that's the problem. So what was happening is once the last piece came out, I didn't pull my phaco probe out and I went for the epinuclear bowl, but that also pulled the bag. In such a case, try not to do that. So that's step 1. But if in case it does happen, and it can happen even in a normal wound, normal case, suture your wounds. So step 1 is suture the wound. Then you place a trocar, but this trocar is placed after you make some flaps because now the bag really can't be used so much. So now I'm making my, I'm doing a peritomy and I'm making a trocar entry, posterior or anterior, depending on the case. In the case before, there were cortical matter as well as the bag. So I really needed to make a posterior one owing to the fact that these pieces might actually fall down. So after making my posterior trocar in this case, I'm now doing the gluteal marker to make these marks and the flaps itself. Once the flaps, partial thickness flaps 180 degrees apart are made, I'm actually taking a sclerotomy, a 23 gauge needle 0.75 millimeters behind the blue limbus and making a sclerotomy behind the iris. Ensure that you see the needle tip. Once this is done, making my corneal incision on the opposite, on the left because I'm a right-hander. Now, I think I'll agree with a lot of the statements that were made. You really need the pars plana approach in these cases, but you also need the limbal approach because you really want to approach this cortex from the anterior side while removing this. So you really want to have a approach, a double approach, an omni approach to this vitrectomy, anterior vitrectomy, which I'm trying to do. Pieces can fall down, and that's why I placed a posterior trocar. But in case that does happen, I have to also put a 3-piece pars plana vitrectomy and try and remove those pieces. Once this anterior vitrectomy is done, I'm actually taking my 3-piece intraocular lens, externalizing one haptic, ensuring that I handshake the second haptic one by one to the opposite side. And once both the haptics are out, I'm now placing this into a Gabor-Chariot's tunnel by using a 26 gauge needle at the base of the flap. Again, 26 gauge needle at the base of the flap. So a small trick over here, which I try to tell everybody, is if you hold it parallel to the haptic, it will turn up. So always hold it perpendicular or on the opposite side. That way you'll be able to turn that haptic down to the base of the flap and it will go smoothly into the tunnel. So these are small tricks that really help in these conditions. Pupil reconstruction can be using pilocarpine, but you always have to wash that out once you're, if you are doing that. In this case, I didn't need to do a pupilloplasty, but if this happens, this is an optic capture, this can happen. If that happens on table, please be rest assured that case will go in for an optic capture post-operatively, and that point of time there will be an IOL tilt that will cause disruption in vision and you will have not the best result that you wanted. So probably do a pupilloplasty to be sure in these cases. Once this is done, you can remove the trocar, posterior or anterior, remove them, put a glue. You can put sutures in these cases as well, but I put glue in most of my cases because I pile up these cases, at least 4 or 5 in every OR visit before I can go ahead and do this. And in summary, I would say that suture the wounds, do a peritomy, place a trocar AC maintainer or a posterior one, fashion out scleral flaps, sclerotomy, anterior vitrectomy, externalize the 3-piece haptics, tuck them in the Gabor-Shariat tunnel, use a pupilloplasty if need be, and closing. And here is the post-op day 3 of the same patient. He was doing exceptionally well. And one extra last point I wanted to add for everybody's viewing is we are also conducting a world webinar on 30th and 31st of this month. So please be there. It's going to be an extravaganza of 2 days, 2 hours a day. Don't miss it. Dr. Roth, you're muted.
Thank you, Dr. Ashwin, for an excellent talk, which took us in different stages right up to the end. Dr. Rajendra Prasad, what is your point of view whenever you have to shift from plan A to plan B? Dr. Rajendra Prasad, are you there?
It's muted. So you're muted.
Hello. Yes, it was a beautiful presentation from Ashwin, and the way he did the first case was excellent. So what I would be a little different in that situation, like especially as you said, the anterior and posterior vitrectomy. So what happens actually when you have the capsular disruption or the PCR? It's more important which already have been said earlier, like your traction on the vitreous, which is going to put on the retina, has to be avoided. That is the most important part. And for that matter, like your anterior vitrectomy becomes more important, because we anterior segment surgeons, we go in for the anterior vitrectomy only. And in anterior vitrectomy, the best way to do the vitrectomy is to do a dry vitrectomy, like where your aspiration rate is very, very low, your vacuum is low, and your flow is low, and you do the vitrectomy with a very controlled vitrectomy, so that you don't put too much of traction on the vitreous. Doing the posterior vitrectomy would mean like you will be removing a large amount of the vitreous, which we actually don't need in these cases. So you need a very partial and a very limited vitrectomy, which has to be just underneath the posterior capsule. And that vitrectomy, the limited vitrectomy, is only possible with the anterior vitrectomy.
Dr. Namrata, you have been doing glued IOLs or?
So I think that was a great presentation, Ashwin, and you showed all the situations very well. We are doing glued IOLs with just one small modification, and that is, instead of the scleral tunnel that we make, we actually, with the help of the crescent, dissect it out. So it's a larger, in terms of width, it's a larger surface area as compared to the tunnel. And the advantage is that the haptics of the lens just go inside that tunnel and kind of, just abut it like that without having to actually direct it. But I think both ways it can be done, and plan B always have to be kept in mind whenever there's a untoward event.
Dr. Ashwin, how do you take care of with the glued IOLs about the tilt of the IOL?
Yeah, so I think that's a very solid point. Tilt and centration, I think they both go hand in hand. The centration is not because of the flaps. I think the most important part of centration is the sclerotomy itself. So where do you place the sclerotomy has to be equal sided on both the sides. Don't go beyond 1 millimeter, because that really is going to be leaving you with a less haptic tuck. So do not do that. Go closer. 0.75 to a millimeter is good enough. Unlike the Yamani, where you go 2 millimeters away, which is different. The second thing in the tilt is you really have to go, if you're going 0.75 on one side, you go 1 millimeter on the other side, you will have some amount of tilt. So try to measure yourself before you actually do this. Measure that distance from the blue limbus and ensure that you enter the sclera at that same point on both the sides. That's the measure to remove the tilt. The second reason the tilt happens, as I said on my video, was because of the iris. When the iris dilates and it reconstricts, that time the optic can get caught in this iris. At that point, it can cause a tilt on the IOL. So to prevent that, you must do a pupilloplasty in those cases at a point where it is needed. Do not do more of it if not needed. Don't do. You need to do only in that side where it's needed. In pediatric patients, I've seen that you probably need to do it a little bit more, but try to restrict yourself to have least manipulation of the iris, because that helps in post-operative dilatation of that same pupil.
Thank you, Dr. Ashwin. I think now we will move on to none other than Naveen Rao, who's Assistant Professor of Ophthalmology in Boston. He's basically from Hyderabad. And the best part is, which, I just was going through it, that his grandfather too was an ophthalmologist. And he's doing fellowship training in corneal transplantation and complex anterior segment surgery. Over to Dr. Naveen, please.
Thank you, Dr. Rohit. Enjoyed the talk so far. So I'll be talking about the Yamani technique, which of course was developed by Shin Yamane, and I have no financial disclosures in that. There are several pieces of equipment that you'll need, but specifically the thin-walled 30-gauge needle as well as low-temp cautery are important for this technique. We developed this flanged haptic IOL diagram to just assist in coming up with a schematic for where to put the incisions. You'll need 2 paracentesis incisions on either side of the main incision, as well as an incision distally for the AC maintainer, unless you're using a posterior infusion cannula. And as I'll show in a subsequent slide, we're going to measure 2 millimeters back from the limbus on either side, as well as 2 millimeters counterclockwise to those marks for the insertion of the needles. I suggest doing a full pars plana vitrectomy for these surgeries, especially in your early cases, because there is a lot of manipulation on the lens in the mid-vitreous cavity. And so I feel anterior vitrectomy is likely not enough to avoid the kind of vitreous traction that the distinguished speakers earlier were already describing. And for this, I like to work with a vitreoretinal surgeon, partly because the lens sometimes drops during manipulation. Now, all of the lenses that are used for this technique are off-label, but I recommend using lenses with PVDF haptics. They are sturdy, they're resilient, and they form consistent flanges. That includes the Zeiss CT Lucia lens, which currently has still limited availability over the last year due to an international shortage, the Santan X70 lens, which has limited availability outside Japan, and the Medenium Matrix Acrylic 401. That is not available in the United States, so I have not used that myself, but I believe that may be available in many countries where these other lenses may not be. PMMA haptics are much more likely to crimp, bend, and break off from the optic, and they form inconsistent flanges. I've used the Johnson & Johnson ZA9003 lens, and I know some colleagues internationally have used that extensively. It's not ideal, in my opinion. It's not as strong as the PVDF haptics, but it can be used. I would not recommend using the AR40 or the LI61AO lens for this type of procedure because those haptics break off much more easily from the optic and they bend easily. They're fine lenses in general, just for this purpose, they're not as good. The needles that you'll need ideally are these thin-walled 30-gauge needles, which you can get from this company TSK in Japan. Their outer diameter is the same as a 30-gauge needle, but the internal diameter is wider than the typical 30-gauge needle, so it becomes much easier to dock the haptics. If you use 27-gauge needles, as is sometimes done by many retinal specialists, the haptics are more likely to slip in or out from those intrascleral tracts, leading to hypotony. In terms of power selection, I like to use a constant of 118.4, and I aim for -0.5 diopter, or some surgeons aim for plano and use 119.0 for the A constant. Ultimately, the effective lens position depends on the white-to-white of this particular eye that you're operating on, and also how far behind the limbus you enter the vitreous cavity with the needle. The further back you are from the limbus, the more posterior the optic will sit, and the more minus you should aim to compensate for this. Regarding haptic locations, it depends which eye. So for me, when I'm operating on a right eye, I like to sit superiorly and place the haptics horizontally. That helps me avoid the cheek, where sometimes a prominent cheek can make it difficult if you're sitting temporally. The ergonomics of where your arms are, where your hands are passing the needles, it's often easier to sit superiorly for right eyes. For left eyes, the opposite. If you're sitting superiorly, you'll tend to bump into the patient's nose. So I tend to sit temporally when I'm operating on a left eye, and therefore can have easier ergonomics for the needle docking. When you're operating on large eyes with horizontal white to white over 12, consider sitting temporally so that the haptics can be oriented vertically where the white to white diameter is less. It's important to use a low temp cautery and not a high temp cautery, which can shorten the haptics too much, too fast. And on these cases, I like to make a peripheral iridotomy to help decrease the chance of reverse pupillary block and UG syndrome. So now we'll see some videos here. I wanted to just show a 1-minute video of the normal technique, and then we'll go over some complications videos and how to manage those complications. You see we're making some paracentesis incisions, a main incision, marking the limbus on either side, mark 2 millimeters back and 2 millimeters counterclockwise to those marks. I'm inserting the 3-piece lens with the leading haptic on the distal iris, the trailing haptic remaining outside the wound. The first needle is inserted and the haptic is docked with a micrograsping forceps. Then the second needle is inserted and the trailing haptic is docked. I like to insert the trailing haptic through the main incision, but some surgeons like to put it onto the iris and then reach in with a paracentesis. Once we've made the flanges, we nudge those back into the sclera. So now let's watch some more fun videos on how to fix the complications that result from this. First, stop the anticoagulation for 2 reasons. You can get bleeding inside the eye, as you just saw, or you can also get subconjunctival hemorrhage, especially when you make a stuttering needle pass. And those subconjunctives can be really problematic for this case because you don't know where you're putting the needle in. So it's very difficult to achieve good centration. Often there's difficulty docking the first haptic, and it's a simple trick. Just rotate the lens clockwise slightly, and that allows the leading haptic to become more parallel with the needle. So it's much easier to dock. Once you've docked the first haptic, one common problem is difficulty now docking the second haptic. And so one way that you'll find this easier is to grab the haptic more parallel with the micrograsping forceps. And you can do that either through the main incision or through a paracentesis. The more parallel you can grasp the haptic, the more easily you'll be able to dock the second needle. Sometimes you have to make a new paracentesis. And so here you'll see I'm struggling by going through the main incision. It's coming in perpendicular to the needle. Then I reach in from my original paracentesis, which I made a little bit too far away from my main incision. And now the problem is I'm grabbing the trailing haptic almost in a perpendicular way, but this time through the inner curve of the haptic. So by grabbing from the outer curvature of the haptic, it becomes much easier to grab it in a parallel fashion for docking. This video I've borrowed from my friend Dr. Brian Kim, and he's developed the trailing haptic first technique, in which the leading haptic is first externalized through a paracentesis, then the trailing haptic is docked, and the leading haptic is then docked. He has very nice videos showing that. And so one of the other common issues is that the first haptic can slip back into the eye before you have a chance to melt it. And so in these situations, you just have to repass the needle. Often you can do that through the same track that you initially made. And then you just externalize it one more time and remelt it. So in these situations, often melting the second haptic, the one that comes out successfully and does not slip back in, can be helpful so that it does not, too, slip back into the eye. You're trying to achieve these mushroom-shaped flanges, ideally, and that's the easiest to do with these PVDF haptics. Now, what happens if the lens is decentered after it's already been externalized? In these situations, it's best to just redock. And what you'll have to do sometimes is pull the haptic back into the eye with a micrograsping forceps, pass the needle again, and then redock it. Now here, another strategy is to make a small peritomy over one of the haptics, and then externalize that, pull it out slightly, trim it, shorten it a bit, while still holding on with a forceps. You can again remelt it, and then push it back in. So notice when the haptic is nudged back in, the centration is much better now. Initially, it looked like it was pulled too far to one side, but once you've nudged it back in, you'll notice again here in this case that it centers quite nicely. Now, another strategy is to just melt one haptic further. Instead of trimming it, you can just melt it a little bit more. So here you'll see I'm going to grab on with a tying forceps, and then I'll just melt until I'm happy with the length of the haptic, and then I'll trim off that excess material and nudge the haptic back in so that the centration can be very good. Again, it's important to really push firmly on that so it doesn't expose under the conjunctiva. Sometimes, though, you'll have a situation where the IOL is both decentered and tilted, And in these situations, you just have to redock and trim the haptics. You can see here how tilted and decentered that lens is. So we have to shorten the haptics as well as make new needle passes so that the centration will be better. And here you'll see this is successful, although there is still some tilt because of how much the haptics needed to be shortened. So notice here how difficult it actually is to get that haptic out of its scleral tract. So for anyone who feels that these are easily slipping out, I think it's just a matter of making sure that you use this thin-walled 30-gauge needle. Now sometimes, despite your best efforts, the haptics will break, and in these situations you really have no choice except to replace the lens. Although I have seen some really interesting videos of a haptic being transplanted from a fresh lens onto a lens that's already inside the eye, and I haven't tried that myself, but I think that it's an interesting concept. I think it's just easiest to replace the lens. The reason I say not to use the AR40 or the LI61 lenses are that the haptics on those lenses tend to break off much more easily than the other lenses in my experience. So when this happens, again, the only thing you can really do is just take out the lens, start over. Often when you do that, you can still make those needle passes through the original tracks rather than making multiple holes. And sometimes when it's all failing and you don't have the right lens, you just convert to a glued IOL technique. And here's another example of how easily the haptics can break off from the optic-haptic junction. So with that, I just wanted to invite you all. I hope we'll be able to see many of you at the American Academy of Ophthalmology this year in Las Vegas, where Dr. Ashwin and I run the skill transfer session called No Capsule, No Problem, Intrascleral Haptic Fixation of IOLs, where all the delegates can learn the glued IOL and the Yamani technique. Thank you so much for inviting me to join you. It's my honor.
Dr. Naveen, is there any way by which we can control the amount of flanging both the sides so that there is an equal flanging or shortening of the loop of the haptic? Because this is the only concern which I feel where we cannot control.
Yeah. So I think one variable that will be easily controlled is when you have lenses that are made of PVDF haptics, they don't shorten unpredictably. They shorten very slightly. The haptic tends to melt more widely rather than melting along its length. Another tip is when you hold on with the tying forceps onto the haptic, hold 1 millimeter back from the end of the haptic, 1 millimeter back, and then hold the cautery 1 millimeter away from the end of the haptic. By doing that, you can minimize the amount of conduction of heat. When you hold on 1 millimeter away, minimize the amount of conduction of heat further along the shaft of the haptic, so that it only shortens about 1 millimeter at most, and it doesn't continue to shorten beyond that.
Dr. Shiraz, are you doing Yamani or glued IOL for that matter? Is he there? Or I think he had to go. Dr. Matthew?
You have to unmute yourself, Shiraz.
Sorry about that.
Okay.
I'm really impressed with all these videos that I've been watching, and myself, I use a combination of techniques. I have to say I struggle with the second haptic quite often, and I sometimes have to do a combination of a Shariot and a variation of the glued IOL technique, but I usually use a buccal suture to do it. I do find that every case is quite unique, and thinking on my feet can be a little bit stressful. Fortunately, I managed to accomplish lens implantation transclerally without too many complications. But it's very useful to watch these techniques and perhaps learn further options rather than what I've been doing so far. Maybe I'll accomplish it all in one go without having to use a combination there.
Matthew, for that matter, in Italy, what is your proposed plan for these secondary IOLs or primary IOLs in certain conditions? Are you there, Matthew? Unmute.
No. Yeah.
Yes, you are on. Yes.
Yeah. Yeah. Well.
What is your preferred method? You use Yamani technique or you use the glued IOL technique?
Sorry. No, I don't use the Yamani technique. I try to improve the glue implant the sclerification IOL with a glue technique like Amar Agarwal showed many times ago, and all related all the different situation that planet.
Yeah, thank you. Dr. G.S. Dhami, we are in that part of the world where iris claw lenses have been used. In your setup, in your center, you have a vitreoretina setup along with it. What is your preferred technique for such situations?
Rohit, I saw excellent videos of Dr. Naveen, really marvelous. But I'd like to know the panel's view regarding retrofixation of iris claw lens. We are very fond of it. It's a few second job, a good artisan's lens after a good vitrectomy, does very well centering and no complications. We are really doing that. Of course, we are following the Yamani Technique and others, glued IOLs, but the easiest and the fastest way we can do is the retrofixation of the iris claw lens.
Over to Dr. Gaurav to take on from now.
Thanks, Dr. Rohit. And after that really interesting presentation, we have our next speaker, Matteo Piovella from the global capital of fashion and design, Milan. And he was elected president of the Italian Ophthalmological Society, the SOI, which represents almost 7,000 Italian doctors. Italy has gone through a lot in the last 2-3 months, and Milan has been in the news for lots of other things, and we are all learning from Italy's experience here in India and preparing. And he has vast experience with almost 234 instruction courses to his credit in the American Academy, the ASCRS, the ESCRS, and he has really improved how to make live surgery programs much safer, having performed surgery in almost 121 live surgery demonstrations worldwide. And it's our honor to have him with us for this meeting, and I request Dr. Piovella to please go ahead with his presentation.
Yeah, thank you very much for this nice presentation. Sorry, but 2 minutes ago I have some technical problem, and now I am, I think, to be ready to do what I really need. Well, 1 second. No, so I advance. Well,
this video presentation
do you see,
try to perfect.
Do you see my video?
Yes, we can. Please.
You can.
Video
okay.
presentation.
So, I prefer. Amar told me that I have only right 5 minutes, so I prefer to record a video, and I will make some comment after that.
This video presentation try to clarify that capsulotomy is superior than manual capsule rescue. This is my standard way to adopt septo in a very safe and very repetitive way, where I have a perfect centered capsulotomy that avoid my standard normal complication rate. I have no problem in implanting the IOL because the resistance of the capsulotomy is effective, and one more time, really nice. Now I would like to show what could happen to face a complication that is capsular radial tears due to poor quality of the cap assembly. In some times ago, the company has some trouble in this assembly, and so the Nitilite ring was not perfectly set inside the cap, and so the capsulotomy was not perfect, and you can see that when you remove the cortex is possible to detect that there is a properly radial cleft. Radial cleft Normally, we think that it's easy to manage, but sometimes there are some sudden situations that provide sudden complications, especially when you are implanting the lens. So what I mean is that with specific attention, you can provide a perfect cleaning of an anterior and posterior capsular bag, and when this the injector are not effective, there is a not controlled opening of the lens that unfortunately is positioning on the edge of the radial cleft, and that's open totally the capsule before, because in this situation is important to provide, you see the opening of a posterior capsule that is really evident, and that is a nightmare. This is a toric IOL, and so I have to apply a lot of difficulty to provide a perfect, a normal comparable result after the surgery. So this is to testify that here you see is with a new upgrade of a tip, everything is perfectly done, but I experienced a capsular radial tears due to poor natural capsular resistance. So that is after the phaco, and that is at the point that I have provide an opening, anterior opening of a anterior capsule, and one more time I provide a perfect cleaning with a lot of attention, but one more time here is mandatory to implant the IOL over in the sulcus, over the bag, and then provide side by side to positioning the IOL inside the bag, and that is what is necessary. What I mean is that mechanical capsulotomy that could be performed with photolaser. Now, recently I adopt Zepto because for me is more effective and cheaper, and I like because I can apply in Intumescent Cataract or in a small pupil cataract. And one more time, we need to provide a certain skill to manage this particular situation. And thank you very much for your.
So what I mean is that in my experience, mechanical capsulotomy is safer if compared with manual. I have a huge experience with Abi Vasavada and many of the other speakers. But if we apply cataract surgery not depending by economical limitation, there is a fantastic technology that decreases the number of a complication rate. Do you remember that the Royal College has a manifesto that tried to decrease 38% of the opening of the posterior capsule? That means that this is something effective and something that is a problem for every surgeon. I am finished.
Thanks, Matteo, and for a wonderful presentation. So, George, I think before you doze off, I wanted to ask you whether what's your favorite? Is it the Femto or the Zepto? And any take on that? And would you be happy to put plate haptic lenses when you have a suspect PC? Oh, sorry, the broken rexus or a broken capsule.
To unmute yourself.
George, we can't hear you. Yeah.
Yeah. Okay. So you asked me whether it's my favorite technique, whether using the Zepto or the Femto. It's like asking me, do you beat your wife often? Yes or no. I don't use either one of those. I use
that's why the question.
All my fingers. So I do a manual capsular rexus. You know, have an idea of what size I want, and I do that. So I don't use either device. I don't think it's all that important to have that. And I haven't seen any data that shows having a perfect capsulorhexis improves outcomes in anything. So that's to answer your first question. Your second question about plate haptic lenses. I think if you have, a PCR and you've converted that to a posterior capsulorhexis and you have a secure capsulotomy edge, then I don't think there's any problem with putting a plate haptic lens into the bag and making sure that it's secure. So I think, I rarely use plate haptic lenses, but if I had a PCR and I had a good capsulorhexis, I still would continue to use it. I think the problem is in Canada is that most of the plate haptic lenses are hydrophilic in nature, and you always have to consider that if you're putting that in and the patient ends up having a retinal detachment and gas being used, that hydrophilic lens may opacify. So I think that always has to be in the back of your mind with a PCR and a hydrophilic lens.
Thanks, George. I'll take a quick comment from Josh and then from Dr. Namrata. Yeah.
Yeah, no, first of all, there was a beautiful video. These have all been wonderful videos. I have a question that's sort of a motif for all of these. Obviously, none of us wants a lens with any degree of tilt. But how much tilt is actually clinically relevant?
Matt, would you like to answer that?
8 degrees.
Well, in my experience, for example, now I am implanting more than 90% of trifocal IOL in my cataract patient, and I don't remember to have some problem about the tilting of the IOL. So, and I am implanting this IOL also after posterior capsule opening. I have implanting also this lens in the sulcus, and so I think that this is dedicated to some cases that is the surgeon after complication or with the difficulties has no the opportunity to take care of the tilting. But if you try to manage it at the end of the cases because you need to apply something positive, I don't think that is really significant. Also, I think that also decentration is not so effective as many colleagues explained some years ago. That is my experience.
So, Namrata, would you like to chip in with your...
My favorite would be, of course, femto. Done only few Zeptos, but I would still prefer a femto or maybe a manual. And as far as the plate haptic is concerned, I think I would be a little wary of putting plate haptic with a rhexis which has gone, astray, or with a posterior capsular tear which is large.
Thanks, Namrata. Mahipal sir, the last word, and then we go on to the next one. You have to unmute yourself, sir. Yeah.
Unmute, sir. Unmute.
Gaurav, the only thing I want to tell the audience or see in case there is a PCR and you have to place it on the sulcus, and as Dr. Payawala was saying that he does all trifocals, there is obviously going to be a change in the power that you need to implant. So that definitely has to be taken into account, and I would, as Dr. Namrata said, I would not do it plate lens in a sulcus, but if you are doing a toric plate lens, that will be an absolute contraindication in the sulcus, because it is not made for the sulcus, and there is a strong possibility of a rotation of the lens, especially if it's a toric trifocal or a plain toric. So in any case, I would prefer to go in for a 3-piece. I would agree with George that in case there is no vitreous disturbance and you have a posterior capsulorhexis which is pretty neat and clean, then possibly you can think of putting in a plate lens. But I have my reservations of putting in a plate lens in the sulcus. But toric, absolutely, I think we should not go with the impression that we can put a toric plate lens in the sulcus and change the power.
Yeah.
Thanks, Dr. Maipal, and thanks everyone for all your good comments, and thanks for the wonderful presentation, Dr. Piwala. Since we are running behind time, I'll introduce our next speaker. That's Dr. Tushya Om Prakash from Amritsar. He's a bright young man with great ideas. He's been doing excellent work, showing us excellent surgeries, new techniques. He's been publishing, and I'm sure he's going to show us some new stuff today, which is going to stand out. Tushya.
Thank you for such kind words, Dr. Gaurav. So today I'll be talking on different case scenarios of posterior polar cataract with pre-existing posterior capsule rupture. I have no financial disclosures, so I'll be discussing two cases. One is posterior polar cataract with pre-existing PCR and no nuclear sclerosis, a patient who was 32 years old, and another patient who was 55 years old with the PPC with pre-existing PCR in nuclear sclerosis of grade 2 to 3. I'll be showing you by step-by-step approach. So I started my case with a primary incision made 90 degree to the PCR axis. Side port incision was made, which was relatively small, which prevented leakage and also helped in providing stability during the surgery. Plan was to make an oval rhexis. Oval rhexis was made 90 degree to the axis of the PCR, which prevented any stress on the PCR. The oval rhexis had numerous advantages. The large arm of the rhexis helped in providing no rise of intracapsular pressure, safe end-to-end sculpting, easy division, easy sub-incisional cortex removal, and smooth IOL implantation. The smaller arm of the rhexis helped in easy IOL capture, nucleus piece retention in the bag, and helped in tamponading of the vitreous. Coming to the hydro procedure. When we talk about the case, PPC case with no nuclear sclerosis, no hydrodissection is done. Layer by layer hydrodelineation is done. So when we have a PPC case with nuclear sclerosis of grade 2 to 3, no hydro procedures were done. Coming back to the case with no nuclear sclerosis, layer by layer hydrodelineation was done. Simulating flax. BSS was injected at different planes to ensure complete nuclear epinuclear separation. Multiple layer phacoaspiration was done. Slow motion phacoemulsification was followed. Safe phacoemulsification techniques with low IOP. At no point nucleus was rotated. As the layers were aspirated by the phaco probe, the outer corticonuclear layer provided a shield to the PCR. With the aid of the chopper, the outer nuclear layer was dislodged and aspirated. It was made sure that the capsular bag was not overinflated at any point of time. Coming to the case with nuclear sclerosis of grade 2 to 3, no hydro procedures were done. My plan was to do stop and chop technique. Safe phacoemulsification techniques were followed with low IOP. Slow motion phaco. Sculpting was done slowly. It was made sure that the two nuclear hemispheres have divided completely. At no point the nucleus was rotated. Cross chopping was done, wherein the nuclear pieces adjacent to 6 o'clock position was divided and emulsified. The nuclear hemisphere was taken out and emulsified slowly. I kept continuing phacoemulsification as I was sure that the hyaloid phase was intact, as there was no peaking of the pupil and I couldn't see any vitreous in the AC. At the last, the other nuclear hemisphere was taken out and it was emulsified. So before taking out the probe, The bag was inflated with viscoelastics. The remaining cortex was aspirated with a coaxial IA. A bimanual IA or dry aspiration is also a good option. The vitreous prolapse or vitreous hydration was prevented by two important steps. First, high sleeve retraction of the coaxial IA. This helped in separating the level of irrigation and aspiration, simulating a bimanual IA. The cortical lamellae were slowly dislodged without aspirating the epinucleus, because this epinucleus helped in shielding the PCR. So once the cortical lamella were freed from all the points, then only the epinucleus was aspirated quickly. So before taking out the probe, viscoelastic was again injected. It was made sure not to overinflate the bag. From the side port, a microrhexis forceps was used, where the posterior capsular rent was converted into a posterior rhexis, a regular posterior capsular rhexis. Vitreous was ascertained. There was absence of vitreous with the triamcinolone in the AC. Multi-piece IOL was injected into the sulcus. And the short arm of the rhexis was used to capture the IOL. By following all these steps, I could have a good centered IOL and a good post-operative best class visual acuity of 2020. Thank you so much.
Thanks, Tushar, for those wonderful presentations. And I'll take this opportunity to ask Lisa to please, Dr. Abhisar, please comment on this. Can you unmute yourself?
Yes, I just did. Yes, beautiful surgery, and I think it involves some of the concepts that Abhay Vasavada has shown us with the multiple planes, as you mentioned in femto. One thing that I want to mention that I think is so helpful in this and posterior polar cataracts, where we don't even know how fragile that capsule is. As you mentioned, we don't want to deepen the chamber or shallow the chamber, and so if you go in at the very beginning with a little OVD between the iris and the anterior capsule, particularly in a myopic patient, go in under OVD control on foot position 0, lift the iris, and then go to foot position 1, then you'll never get that retropulsion of the iris that occurs with posterior block, with reverse pupillary block in the myope or the patient with poor zonules. And so you can assure that you don't over deepen the chamber, which will easily happen, and that's the end of the case already, you know, on a myope or someone just with very lax zonules. So it's just one little detail. You handled that beautifully, and I think it makes so much sense. And the only question is whether at that point that you finished everything perfectly and you've completed the posterior capsular rhexis, whether you want to put it in the bag and then optic capture into burger space in order to totally hermetically seal that anterior hyaloid from the front of the eye. Then you can be more elaborate in removing your OVD anteriorly. But once you have it captured in either anterior or posterior or both, you're really in good shape. So I congratulate you on a beautiful measured approach. And that's the only thing, little tiny detail I would add, so you don't over deepen any eye when you go in. Foot position 0. Lift rather than just resolve.
Thanks, Dr. Abhisar. I'll take John here and ask him that how often, or Tushar showed very nicely how to convert the pre-existing break into a continuous rhexis. How often would you be able to do that in a posterior polar cataract with a break in the posterior capsule? Is it easy or difficult, and some pearls on that, John?
When I do a posterior polar cataract, for the most part, I leave the posterior capsule alone. I think that's something that I will deal with the YAG capsulotomy later, for the most part. Again, this is a beautiful case, and things went absolutely well. Just a couple of things come up. I think the underlying theme of this entire conference is let's keep this a closed system. Let's keep the pressure normal in the anterior segment. Every single case that we've seen goes back to that. And that's really, really critical, and how this case was managed so well. I think once we get away from that is when we have problems. And we didn't talk about that because all the cases went well. But I think that is the underlying issue here. Keep normal pressure in the anterior segment. It keeps the vitreous back, it keeps everything up in the front, and it makes life a whole lot better. So beautiful case. The one thing I would add when making any of these capsulorhexis, I've seen people talking about an oval capsulorhexis. I still like to make my capsulorhexis round and smaller than my optic, so that when I do optic capture, I also get a nice barrier separating the anterior segment from the vitreous cavity. If I have an oval opening, I'm a little bit careful that I'm not going to be able to maintain that. And that could be a source for vitreous coming around. But beautiful case, fantastic case.
Thanks, John. We have a panel of a lot of experienced surgeons. Is there anybody on the panel who would be willing to do a femto-assisted surgery with a posterior polar cataract with a break in the posterior capsule?
Yeah.
Yes.
Is there anybody who would want to? Partha?
Yes.
Want to say as well.
Can I quickly make two comments? One is excellent surgical demonstration, Tushar. Really, congratulations for this. One comment that I would really like to make is your making of that posterior capsular rhexis with a PPC and a rip which was transverse, converting that into a posterior capsular rhexis is very, very difficult. And you could do it because it did not digress right up to the equator, and you had the edges in view. So you were lucky, but the expertise was excellent, number one. Number two, we also did see Dr. Lisa's video in which she made a capsular rhexis out of a posterior capsular rupture, but she made it through the main port with a forceps. That was the Utrata forceps. So I think your technique means I would go by your technique by placing the micro forceps from the side port, which gives a more anterior chamber, a more stable anterior chamber, and there's less digress of the viscoelastic from the anterior chamber. So I think this definitely is, these are two small things.
Wonderful tips, Partha. And Namrata, quick one that you wanted to add?
I just wanted to add, and I think Dr. Vasavada has also published the same, just a modification of that. When we do femtocataract, we actually have 3 cylinders, 2, 4, and 6 millimeters, and have 3 chops, 6 millimeters in length. And then block by block, we just, eat up those things. But of course, if you have a posterior capsular end, then you have to, offset it a little bit more anteriorly because you can't go through and through.
And also the energy might have to be played with a little bit.
Yeah. Not the energy, but you have to just offset the
I know, offset, and maybe I would also go with a technique which uses less energy so that less cavitation, bubbles as well. So great points, Amrita, and we cannot finish this without taking a word from Dr. Vasavada, who's the master of posterior polar cataracts.
Thank you. I think I will recognize the teaching of Dr. Osher in this entire topic, but I would suggest mechanical inside out delineation. If you're not doing a femto, I would prefer femto, but mechanical inside out would reduce the chance of inadvertent subcapsular hydrodissection. But Tushar, you did a great job and beautiful cases. Wonderful.
Thanks, Dr. Vasavada, and thanks, Tushar, for those wonderful videos and wonderful tips. I think take-home messages are great, and that leads us to our next presenter, and none other than Dr. Shiraz Daya from the UK, and it's my privilege to introduce him, dear friend, Director and Consultant, Corneoplastic Unit and Eye Bank, Queen Victoria Hospital, East Grinstead, and he's the Medical Director of Center for Sight all the way since 1994. And more than 115 publications in peer-reviewed journals. He's been there on the par list of ophthalmologists 2018-19. We keep enjoying all his presentations. He's dynamic, and a lot of new stuff that I keep learning from him in both cataract and refractive. So, it's my privilege to have him speak here. Please go ahead, Shiraz.
Oh, thank you very much. Can you see my screen?
Definitely, yes.
I wonder which one it is.
You can go to the presentation. I mean, switch on the slideshow.
Are you on now? Can you see
Yes,
the
now
slideshow?
it's good now. Yes.
Do you have the full screen? Do you?
Yes. Yes. Thanks.
Great. Well, thank you very much for inviting me to participate. I feel like a bit of a fraud here because I'm going to be talking about high technologies and trying to avoid troubles by using these. These are my financial declarations. I am the medical monitor from Bausch & Lomb, and I'm also involved with Excellence in the capsulase there. I'm going to be talking a little bit about two techniques. One's femtosecond laser, and the other is capsule laser as well, which uses a dye staining on the capsule and performs a capsulotomy. And we call this selective laser capsulotomy. This is the capsule laser, and you can see, this is just to illustrate this. It's even faster now. It used to be a second, and now I can do a capsulotomy in 0.33 seconds. And that's it there. So that has quite a few advantages, which I shall discuss in a moment. But what we did find, this is in collaboration with Sunfik Chi, I expect she's gone to bed now, that we demonstrated that bigger capsules in this sort of range are stronger, and discontinuous capsules are actually weaker. And a further study, we compared selective laser capsulotomy with manual capsulorhexis and flax. And what we found is that, contrary to some other studies, the capsule laser, selective laser capsulotomy was stronger than manual capsulorhexis, which in turn was stronger than flax. So although I'm really 100% flax surgeon, I'm now doing some SLC, it is weaker, but actually I do enjoy using the femtosecond laser. And I think one of the things is that the fragmentation is probably underestimated in terms of its value. So why is SLC stronger than CCC and flax? And if you take a look at the SEMs here, you'll see that this is probably the reason why. The capsule laser, the capsule falls over in itself and it becomes like a double capsule. And there's also some amorphous change in the collagen, which makes it a bit stronger. This is a manual capsulorhexis, which I'm sure you've seen. And this is a decent SEM of a femtosecond laser capsulotomy. We published this not so long ago in terms of comparison. So with flax, what can go wrong? We can get loss of suction, you can get anterior radial tears, skips, tags, and you can get a loss of lens posteriorly. And this is a publication by Roberts and company showing, demonstrating that two of out of the 51st cases had posterior capsular rupture and lens loss after hydrodissection. And I found something similar. This is Miyake talking about capsular block syndrome. Well, there's the three stages to this. You can inject fluid, and you'll get distension of the posterior capsule. This is in hydrodissection. If you're too vigorous, the lens can come forward and widen the anterior capsule, and then it eventually can break the posterior capsule. And this is kind of what happens in femtosecond laser cataract surgery, where at this area here, you get what's probably a fusion of cortex to the anterior capsule. And when I did this myself, this is one of my first cases. Here I'm doing the conventional hydrodissection. You'll see the anterior capsule widening. And that was kind of scary, and everything was quite stiff and solid. I had to rock the lens to release the fluid there. I decided I was going to do that anymore. And so what I used to do was try and take out, break up the lens. So this is an animation showing what exactly happens here. You've got inject fluid, and you'll see, yes, the hydrodissects, but it gets sealed and it keeps staying in the posterior capsule. So what we did is I abandoned this, and what I used to do is break the lens up and use a shoehorn technique to take out each quadrant. And that was kind of a laborious thing to be doing. And one day when I was doing this, I decided to use a cannula to do this. This is a cannula we use for hydrodissection. I'm just taking that capsule out there. And you'll see me injecting fluid by mistake. So I'm going into the fragmentation there. And by mistake, I inject the fluid, and that hydrodissected the lens. I said, wow, I did that by mistake. Well, maybe I should try and do that by design. So I did, and it seemed to work very well. spin. That you can see that lens is spinning beautifully inside the capsular bag, and we went on to develop a hydrosection cannula with Bausch+Lomb, and this is translenticular hydrodissection in action here. So what we do is we use this. It looks a bit like a phaco chopper, but it's really a cannula, and then we go into the fragmentation, inject fluid. You can see that bubble displaced to the side there, and then we can rock that lens, and it rotates beautifully, and that makes the lens loosening much easier. We can even use that chopper to break up the lens and do like a pre-chop further to get the fragments out. And this is an animation illustrating the same thing here. So why do we manage to hydrodissect without distending the capsule? Well, that's because any excess fluid goes right out where the cannula is, and that avoids breakage. And we found that doing femto certainly reduced effective phaco time statistically significantly, and translens compared to without translens reduced it further. And this we published a while ago. This is just a cortical cleavage to help irrigate out cortex and make it a lot easier to remove during femtosecond laser cataract surgery. And it makes the whole process very, very rapid. So the time in the eye is a lot less using some of these little maneuvers that deviate a little bit from conventional cataract surgery. And this is a case of a patient who had cataract post-pars plana vitrectomy, but he had dense, almost, it was a brown, brunescent leather cataract. And all I could see was a brown lens there. And he'd waited for about 2 years before he decided to come and see us. He'd been done in the United States, and he was traveling through the UK. I took a look at him and said, yeah, I can do your surgery. And I went ahead, and you can see this is after doing flax, I could see the lens descending before I even bothered to do anything. And that was it. It went into the back of the eye. I called up my retina guy, Tom Williamson. I said, what do you think I should do? Should I just leave them for you to deal with? And do you want me to put a lens in? He said, no, I'll put a lens in. It'll save me the trouble of opening his incision again. And hopefully he won't have any retinal tears or anything. We won't have to put any gas in. So that's what I did. And when I took a look at his video again to see what I did wrong, what I didn't notice was this. So the online OCT on plaques can be quite useful sometimes if you take a look at this. So now actually what I do now is every patient who's had a pars plana vitrectomy that has a cataract, I will dilate them and image the posterior capsule and also take a look at it if I can see through it as far as I can. Often they're white cataracts, so they're very dense nucleus sclerotic cataracts. That's something to be aware of. These are Tom's own results in almost 1,400 pars plana vitrectomies. He admitted to lens touch in 3.7, and when he did cataract surgery in those patients, these are phakic vitrectomies, 11% had a posterior capsule rupture. So that's quite significant. In ones that there was no lens touch after pars plana vitrectomy, the rate was 1.4%. So retinal surgeons often touch the lens, and that's something to be aware of. This is a white intumescent cataract that I did. Well, actually, it was white cataract in a young chap who was about 34 years old. And I didn't see him for 6 months, and he came in to have cataract surgery, and I was doing flax on him. And I didn't realize he was actually that intumescent until I saw this OCT, and this is his video. You'll see that we've talked about flax being useful in intumescent cataracts, but that's really not necessarily the case. Let me just accelerate this a little bit in the interest of time. So you can see what I've done here is I've gone ahead, and you can see this white cloud going across all on one side. That's fluid leaking out. Now, the femtosecond cataract surgeons will tell you this: if you've got any opacity, it starts to interfere with further ablation. Now, I was worried that this was cut on one side, and maybe I was going to have an Argentinian flag type situation. So I abandoned the surgery, and I took him to the operating table and I took a look. I was just doing his limb relaxing incision for good measure here. I had abandoned the surgery, so I couldn't do it with the femto. And I've got this cloud of material inside the eye. So I better put some trypan blue in while I've got the option. Not sure it's going to do much with all that material in the eye. And then I hydrated out all that liquid and cortical material. I realized he actually had an anterior plaque there as well. And I had a superior opening from the femto. So yeah, I'm just aspirating. As I said, he was a young guy. And I just aspirated his cataract. You can see that anterior plaque there that was already been discussed in the symposium. Well, that was achieved without any radial tears. As you can see, the trypan blue didn't stain the capsule very much. And here I'm injecting in a trifocal lens. I got to go around the edge there. And once that was accomplished, then I did an anterior capsulotomy, completed it. So I was kind of relieved that that happened, and that sort of made me wonder how I should approach these patients in the future. And really, the best option is probably to do a double anterior capsulotomy with flax, a small one, and then followed by a big one, and making sure that the ring, this ring scan is absolutely flat as possible when doing the procedure. This is another case of a high hyperope. A 44-year-old had plus 15 diopters of refraction. She had a very shallow anterior chamber. She required a 42 diopter lens. So I thought I'd do this using capsule laser with a trifocal and a piggyback monofocal. And this is what happened. You know, hyperopes, as we all know, can be quite hazardous. This is capsule laser in play, one of my earlier cases. So we stain up this capsule with a very, very concentrated solution of trypan blue. And this is a very, very abbreviated video showing the capsulotomy taking place. And then we go ahead and we take out the capsule. Let me move this on a bit. And I go ahead and phaco and manage to accomplish all this. And then I take that phaco and I can see that ovalization of that capsule. That's not from capsule laser. You take a closer look, you see the zonules all dehisced over there. So putting some viscoelastic in the capsular bag and using a CTR to brace it. And that seems to have helped. I'm going to now go ahead and I'm injecting in the trifocal lens, Physiol Micro F. Now I need to extend the wound a little bit. I'm using the softport 20 diopter lens and injecting that into the sulcus. You see that the edge of the capsulotomy with the capsule laser is quite intensely blue, it visualizes well, and it's also very, very strong. And so here once I've got this in place, I'm just going to do this anterior lens capture, optic capture. So both lenses are in the bag, but the anterior ones and the haptics are in the sulcus. And that's the value of something like capsule laser giving you good visualization and a strong capsular edge. Thank you for your attention.
Thanks, Shiraz. That was brilliant. So that brings me to a question for you. We saw Dr. Piovella show us some Zepto-assisted surgeries, and you worked with the femtosecond laser and now with the capsule laser, and with that really nice intumescent cataract where that cloud can sometimes impede the laser from reaching the capsule, even though some of the new lasers have the capsulotomy over in less than a second, and you can the catalyst for that reason is my preferred machine. Yet I have a question that the capsule laser, will that get impeded as well if you had a real intumescent cataract which would suddenly break? Because how fast is the capsule laser in finishing off the capsulotomy? Do you think it could still have tags? And do you think Zepto may be a better technique, because Zepto edges are also very strong? They're really strong, somewhat like what you showed on the capsule laser.
If you can do this in a third of a second, I think that you're pretty much okay. I've not done any yet. I was sent some videos of ones that have been done, but I've not seen any escape, because the viscoelastic that's used with capsule lasers is very heavy and exerts quite a lot of pressure on the capsule. So there's not much release of fluid. I don't know if those particular videos had enough fluid in them, if they were intumescent and Morganian or not. But it didn't seem to do much. But they certainly accomplished a capsulotomy. This is Jorge Alio's video and also Pavel Stadolka from Czech. They both have done Morganian cataracts with capsular with very good success.
Yeah, thanks. So Dr. Piovella wants to comment, yes.
Yeah, well, I think that what the Shiraz show was outstanding, but it's very clear. We don't need to take care the resistances of a different of the capsule with different device, because if it should be not effective, we can't adopt that, because it's practical. What I need is something that do not create a radial cleft when I perform the surgery. And obviously, if you apply this technology, the Zepto, the laser, the Stodulka laser or the femto laser, it means that works. It's not important. This is strength, this is less, and then the technology that we adopt was not ready. Everybody knows the laser that was shown for the first 3 years was not effective, has a lot of problems. It takes 1 hour to perform a surgery. So now the world is totally different. And also when we speak about PCO after diffractive technology implantation, in my practice since 8 years, we apply YAG laser capsulotomy in 100% of the patients within 1 year. Because if you don't manage that, the patient lost near vision. And so it's not effective, and you can't spread the technology to the majority of your patients because it's a practical feedback that need to take the life. So another thing, if everybody understands that it's not possible to implant a multifocal IOL after an opening of the posterior capsule, and that this lens is not possible to put in the sulcus, this means that we have no practical experience in that. So vice versa, if you apply that in 10, in 20, 25 patients, and you can get the result, you understand that we have no the right sizes of the IOLs, because different back, different sides of the back, we need to implant different sizes of the IOL. So what does it mean? That in big eye, if you implant a plate optic in the sulcus, can be the truth better rotated, but it's more easy better rotate a C-lobe IOL, because C-lobe IOL has also the reverse flexibility when you are implanting the back for about the axis. So these are news. These are something that we need to provide experience. And I think that Sharon understand and agree with me that when you adopt a technology, it takes a lot of time to have a perfect control of the technology. And then he decides, it's good, it's not good. If it's good, he apply routinely. If it's not good, disappear, and nobody has to discuss about that.
Thanks, Dr. Pivel. I think we got the message. And, I really liked what Shiraz showed was with that design for the cannula, which can, kind of, it looks innovative, but it also looked a little scary. Dr. Chi here has a lot of experience with femto-assisted surgeries. Did you see that nice device which he used to rotate the nucleus and also to put a jet of fluid for the hydrodissection into the groove? Would you care to comment on that, Dr. Chi?
Yeah, I know. Before Shiraz had done that many cases, he shared that with me. But honestly, I hardly hydrodissect my femto cases. I do, femto in many, many cases. And I find that you hardly need any fluid because of the gas bubble. So,
pneumodissection.
Yes, exactly. And, if I have complex cases, like I do posterior polar, I just do viscodissection just up to the equator and I stop there, and only in the sub-incisional areas. And, you can do cross-chop to get all your pieces out, which means that you don't have to rotate even the routine cataract. So that really makes things so much safer, and it's faster also because you save one step.
Thanks, Dr. Chi. I think I agree with that. And I think we'll take a quick comment from Dr. Naveen, if he would like to comment on the capsule laser. Do you have, I don't think in the US you have, is it commercially available yet? And what is your...
It is CE marked, is commercially available outside the United States. Sorry, Naveen.
Yeah, sorry. A lot of things I wish we had.
Naveen, do you prefer the femto or the zepto, or you have probably access to both of those? What's your preferred technique?
Yeah, I've used femto in the past. I just found it a little prone to various glitches because personally I just don't use it very often. So for me, I primarily use manual techniques.
Wonderful. I think I'll pass on to Dr. Rohit to take quick comments from all our panelists before we close. I think we've exceeded time. Thank you for giving me this opportunity.
You know, one question which has been cropping up is mainly with Dr. Vasavada sir's this thing. So one question from Dr. Ravi Vora is, what change in IOL power you do here in comparison to in the bag calculation? Number one. So how much astigmatism you come across in such cases? Will you do trifocals in such cases?
I would add, make it half a diopter myopic. I do not see that it can induce astigmatism, and I do not use multifocal lens because I use 3-piece IOL and I don't have any 3-piece designed trifocal lens with me.
Yeah.
So half a diopter more.
I think we have overshot time, and I would like to thank Dr. Amar Agarwal for the opportunity which he has given through IRSI to conduct this webinar. All talks were top of the line, and I think it was take-home messages right across all the talks were there to be taken in home this time, not by home, whatever you want to call it like. And with this, I would like to thank all the foreign faculty who took time out on the Sunday to be there up in the morning to be with us. But we have, audience right across Latin America and, Australia, Africa, even South Africa, who have come in. And thank you again very much for being there, each one of you, because without you, it would not have been possible. Thank you very much.
Thank you, Rohit. You did a wonderful job. Thank you. Thank you, Dr. Luthra, Gaurav. Great, great job.
Thank you.
Thank you, everybody, for making it such a lively discussion.
And you need to thank Dr. Chi for staying up late, not getting right?
That part was missed. Sorry.
Superb surgery.
Yeah.
Thank you.
Yeah. Thank you.
Thank you.